конференции. Меня зовут Курбанов Максим Владимирович, я являюсь руководителем операционного офиса по Северо-Западному федеральному округу в городе Санкт-Петербурге. И ознакомлю вас с мерами безопасности при проведении нашего сегодняшнего мероприятия. Наша компания заботится о безопасности людей, поэтому мы рекомендуем: будьте внимательны при наличии на входе и выходе из здания стеклянных дверей, высоких порогов или ступеней. При движении по лестничным маршам держитесь за перила, не разговаривайте по мобильному телефону во время движения и соблюдайте осторожность на скользком покрытии пола. Здание оборудовано автоматической системой пожарной сигнализации, и если вдруг вы услышите сигнал тревоги, хочу сразу оповестить, что на сегодня никаких учебных тревог не запланировано, поэтому в случае, если вы услышите сигнал тревоги, без паники встаем и следуем к эвакуационным выходам, следуя по указателям. Их два, мы находимся на втором этаже, один выход справа, другой слева от вас. Лифтами не пользуемся. При использовании лестничных маршев, еще раз повторюсь, пользуемся перилами и выходим к месту сбора, которое располагается у главного входа. Место для курения рядом с парковкой. И в случае ухудшения самочувствия можете обратиться к организаторам мероприятия. Мы вас отведем к медицинской аптечке и в случае необходимости вызовем автомобиль, бригаду скорой медицинской помощи. Желаю всем безопасного, продуктивного дня. Всего хорошего. Спасибо за внимание.
Дорогие коллеги, доброе утро всем. Значит, мы начинаем сегодня второй день. И организаторы надеются, что второй день пройдет не менее успешно, чем вчерашний. Значит, много отзывов нам поступает. В общем, это замечательно. Сегодня мы начинаем нашу работу с секции, которая называется «Промышленная гигиена удаленных объектов. Анализ рисков для здоровья работающих». Значит, модерировать будет профессор Корчевский из Соединенных Штатов дистанционно. Ну, а мы с Борисом Александровичем Ревичем будем, в общем, здесь ему помогать, ассистировать в случае необходимости. Значит, я еще хочу, предваряя эту сессию, сказать несколько буквально слов о том, о чем я, в общем, вчера говорил. Тоже, что не случайно вот эта тематика включена в повестку нашей конференции, потому что, к величайшему сожалению, идеология оценки рисков для здоровья работающих пока в России фактически можно сказать, что не востребована. Либо она проводится не так, как это делается с передовых позиций. В общем, есть различные методики, есть различные взгляды на этот счет, но тем не менее, в общем, нельзя сказать, что это удовлетворяет требованиям сегодняшнего дня и сегодняшним достижениям мировым в этой области. Поэтому мы пытаемся эту идеологию продвигать на российских просторах. И в общем, у нас есть уверенность даже, что в общем, это все даст в результате плоды. Потому что Россия все же продолжает быть интегрированной страной в мировое экономическое пространство, а требования для промышленных крупных компаний в мире, в общем, они универсальны. То есть, наверное, главным всегда является охрана здоровья человека и охрана здоровья персонала, потому что это является основополагающей мировой ценностью. И мы надеемся, что, в общем, как-то это понимание придет. Значит, я с удовольствием передаю слово нашему модератору, профессору Корчевскому, который собрал совершенно звездный состав спикеров на этой сессии. Это большая очень редкость, что мы, в общем, таких статусных лекторов сегодня услышим. Это очень здорово. Андрей, спасибо огромное. Я передаю вам слово.
Thank you very much, доктор.
Большое спасибо, доктор Карпов. Я благодарен вам за предоставленную возможность участвовать и модерировать данную сессию, посвященную промышленной гигиене удаленных объектов и именно анализу рисков для здоровья работников на удаленных объектах. Мы все понимаем, что что для предотвращения заболеваний самым эффективным подходом к борьбе с такими ситуациями является предотвращение последствий. И очень приятно видеть, что в России люди тоже занимаются решением данной проблемы и постоянно обсуждают насущные вопросы. 2 года назад я участвовал лично в конференции в Томске. Сейчас для нас всех большая честь приветствовать прекрасных спикеров, групп ученых, которых я очень уважаю, которые представляют различные организации США. Я уверен, что тема промышленной гигиены на удаленных объектах и подходы к анализу рисков для здоровья работающих и предотвращения заболеваний и роль промышленной гигиены в период пандемии, все эти аспекты будут сегодня тщательно и детально обсуждены нами на нашей сессии. К сожалению, у нас не так много времени на каждого спикера, поэтому давайте будем считать, что конференции в Томске мы сможем лично присутствовать и пригласить наших спикеров в прекрасный город Томск, и все вместе встретиться и обсудить интересующие нас темы. И у нас будет возможность поделиться знаниями, информацией и опытом, а также передать навыки, которые являются очень важными для развития квалификации любого медицинского сотрудника, для людей, которые в целом работают на удаленных объектах, и в частности в удаленном здравоохранении. Не только в России, но и в других странах. Это очень важно. Сегодня первым спикером будет Лоренс Слоун. Для меня большая честь представить его сегодня здесь. Он генеральный директор Американской ассоциации промышленной гигиены. Это ассоциация одна из лидирующих организаций в мире, которая включает члены которой являются специалистами в промышленной гигиене или другие специалисты в смежных профессиях, которые так или иначе занимаются гигиеной труда и здоровьем сотрудников. К сожалению, у меня не так много времени, чтобы зачитывать всю биографию Лэри. Я думаю, у вас будет возможность, если вам интересно, посмотреть на веб-сайте конференции более подробно о его достижениях. Но он очень замечательный человек, он самый выдающийся ученый, из которых я знаю. И особенно в период пандемии он приложил все усилия, чтобы вывести Американскую ассоциацию промышленной гигиены на новый уровень. Это яркий пример анализа рисков не только как отдельная методология, а как глобальный подход к предотвращению заболеваний с использованием научных знаний, всевозможных инструментов, знаний людей для того, чтобы объединить общие усилия и предотвратить заболевания. Темой выступления Лоренса Слоуна является вмешательство Ассоциации промышленной гигиены во время пандемии. Роль сообщества.
Inviting me to present. This is the first time that I present to the particular audience here. So in the next 15 minutes, I'm going to just spend some time talking about the organization, the American Industrial Hygiene Association, AIHA, a little bit about who we are, and then what our response has been to the pandemic. As Andre said, the last 18 months has been quite chaotic, as you can imagine. I am leading the organization, like many others, virtually. We have not been in the office for the duration of those 18 months, and so everybody is working from home. All of our meetings are virtual. Our board meetings have been virtual. Everything is through the internet. So it has been a challenge, but we have really managed to succeed in wonderful ways, quite frankly. The way that we have collaborated with the membership and to bring ourselves together to develop very important resources to address the pandemic. So with that, I'm going to talk very briefly, first off, about what is the AIHA's purpose. Our mission statement is to empower and advance those who apply scientific knowledge to protect all workers and the communities in which they work from occupational and environmental hazards. And my fellow presenter, Mike Larinaga, is going to follow me, and he's going to talk about the impact of climate change. And climate change, of course, is one of the key environmental hazards that are facing workers across all industries as we look ahead. So that is the purpose of the organization, and our vision is an aspirational statement. We would like to live in a world where all workers and their communities are healthy and safe. In our current strategic plan, we've created what we call a value proposition statement. This is basically a statement that the occupational health professionals can use when they speak to business leaders, when they speak to their clients, when they speak to people that are not trained in industrial hygiene. This is a statement that explains the value that we provide to society. And so the statement reads that AIHA members are scientists and professionals who protect the health and safety of workers and communities by reducing risks and safeguarding operations to help organizations operate efficiently and without interruption. So that's a little bit of background on who we are as an organization. This slide shows what we call the organizational chart. And without getting into a lot of specifics, let me just say that AIHA is a rather unique organization. We are a nonprofit society. And on the left-hand side, you will see the AIHA logo. That represents the 8,000 members that make up the association. We do publish a peer-reviewed journal called the Journal for Occupational and Environmental Health. We have, on the right-hand side, we have two foundations. One is the Education Foundation, which awards scholarships to students. And the other is the Guideline Foundation, which, among other things, develops what are called emergency response planning guideline values. These are values that are designed to allow communities to know if and when to shelter in place if there is an accidental chemical release to the environment. So ERPGs are basically the community-based occupational exposure limit to a threshold limit for the workplace, like a TLV, for example, threshold limit value. So we develop those values over here. And then in the middle of the slide, we have three what are called limited liability corporations. The first is a lab accreditation practice, and these include industrial hygiene labs, predominantly in North America. We have what's called a proficiency testing program, which basically helps labs prove that they are competent in what they do. And then finally, we have a registry program, which consists of three different registries. Registries are basically like credentials. And there are two registries that have been around for quite some time. One is the Asbestos Analyst Registry. It's been around since 1974. And the other is a little bit newer, and it is a Safety Data Sheet Author Registry. So these are the people that develop the safety data sheets that are associated with chemicals. So that consists of the entire AIHA organizational structure. And what's not reflected here are the 65 local chapters that are around the United States and Canada. And so it is a rather complex organization, but a very robust society with over 1,000 members that are actively serving on the various technical and professional development committees. So let's switch over to what our response has been to the COVID pandemic. Back in the spring of 2020, when we still didn't really know a lot about the virus, we recognized that there were tens, if not hundreds of thousands of small businesses in the United States that were not receiving practical guidance from the U.S. federal government. And so we decided as an organization that we had a responsibility to develop very clear and comprehensive guidance to help businesses, small businesses, reopen their operations carefully and safely. So we formed a task force, and the task force was called the Back to Work Safely Task Force. And so when we developed this task force, we sat down first and we thought, what is it that small businesses need to know? What are the things that the small business owner who doesn't know anything about occupational health, what is it that they need to know in order to safely reopen their doors? And we knew that whatever we developed had to be written in language that business leaders would understand. And that's not always easy to do. You have to translate the science of occupational health into language, into recommendations, into guidance that business leaders are going to understand. And so we decided that, first off, all of the directories, all of the guides that we develop were going to be designed for small businesses. And we decided that we needed to focus on small businesses because we knew that these businesses did not have the benefit of an industrial hygienist. We knew that the language had to be clear, it had to be concise, and it had to be very action-oriented. And the very first guidance document that we developed was for restaurants, a very critical part of any society. And we ultimately developed 27 different guidance documents, and I'll describe those industry sectors in another slide or two. And we knew that, again, we had to make sure that the guidance was tailored towards the comprehension of the business owner, the person who really didn't know anything about worker health and safety, but knew that they had to figure out a way to reopen their business. Because like many other countries at the beginning of the pandemic, all of the American society was shut down, with the exception of the medical community, hospitals, doctors' offices, supermarkets, and pharmacies. Pretty much all of the other businesses were shut down for a good 6 to 8 weeks. And so as we knew that we were going to reopen the economy in the late spring, we had to get this guidance document out into the society and get it into the hands of those small businesses that needed the guidance the most. So when we developed the guidance documents, we decided to develop the framework from 3 different perspectives. Number 1, what should the employer be doing? Number 2, what should the employees be doing? And number 3, if it was an industry where there were customers that were coming in from the general public, what were their responsibilities and obligations? And so when you look at these guidance documents, all of them are designed from those 3 perspectives: the employer, the employee, and if it's an establishment that takes customers, the patron or the guest. And at the back of each of these guidance documents, we also provide a listing of other association resources, including guidance from the U.S. federal government. Now, I will tell you that we are not always in agreement with the U.S. federal government. And so when you looked at the guidance from the OSHA, the Occupational Safe and Healthy Administration, the NIOSH, and the CDC, Centers for Disease Control, from time to time, our guidance has not been necessarily aligned with what those organizations have said. And we have decided that it is best for us to deliver this guidance, to develop these recommendations based on the science of industrial hygiene. This slide shows the traditional chain of infection between the source, if you will, and the host. And so as you read through these documents, we decided that the organization of the material would follow what's called the hierarchy of controls. Many of you on this call probably understand that the hierarchy of controls looks like a pyramid, and at the top of the pyramid is the most effective control strategy, which is elimination of a particular hazard, down to engineering controls, administrative controls, and then personal protective equipment. And so as you read through these documents, they're all organized from the perspective of highest, most restrictive control to the least restrictive control. And the purpose of the guidance is to break the chain of infection, to figure out ways to reduce the opportunity for the virus to transmit from the host to the receptor. So this slide shows the 27 different industry segments which we have developed guidance documents for. They range from amateur sports. So for example, in the United States, if you are a little league, which is a baseball coach, there's guidance for that environment, all the way to transit systems, buses, subways, as well as warehousing and transportation hubs. And again, the purpose is to focus on small industry sectors. So all of these 27 documents have been translated into Spanish, and we just released the version 2 of all of them in English, and we are going to be updating the Spanish translations of all of them in the next couple months. All of this information is downloadable for free. There is no cost, and you go to www.backtoworksafely.org. In addition to the Back to Work Safely documents, we developed a series of other COVID-19 resources. You will receive a copy of these slides, and there are hyperlinks on the slide. So each one of these names that is underlined in blue is a hyperlink to our website, and you can download all or any of these materials, again, free of charge. These documents pertain to the hierarchy of control. So for example, we have a guidance document on UV disinfection. We have other documents on cleaning and disinfection of facilities. Another document on the proper use of respirators for healthcare workers and first responders, and so forth and so on. So there are a variety of resources, and we invite you to take a look and download whatever you wish. So in terms of the theme of this particular meeting and the mission of your convention, why are AIHA activities important to remote workers? First of all, we all know that the pandemic has created very special challenges for occupational or industrial hygiene programs at any workplace, but particularly remote locations where you have isolated workers, and if you have service that is coming and going to the remote location, it opens up the opportunity for the person coming in from the outside world to carry the virus into the remote location. And so then what happens if the person coming in from the outside world transmits that virus to the workers in that location? So we know that our guidance in the Back to Work Safely and some of these other resources are very relevant and will be useful for those that work in remote locations, because breaking that chain of transmission that I mentioned on the other slide applies to any work location. The pandemic has also increased awareness about the importance of our profession. This has been a very exciting time for AIHA, and it's been a great opportunity to raise the visibility of who we are as an organization and the value that we provide to society. The challenge for us will be, once the pandemic is behind us, we need to maintain the focus on the importance of our profession in protecting workers from a variety of hazards in the workplace. And I am optimistic that this pandemic has basically raised the level of sensitivity about how important it is to take care of our workers, again, in remote locations or in conventional physical plant locations. And finally, I want to just draw your attention to one of our many guidance documents, and there's a link to real-time detection systems. We feel that the pandemic has accelerated the use and the importance of monitors, sensors that are worn on the worker so that they can measure real-time changes to hazards in the workplace, including, for example, noise and body temperature, blood pressure, resting pulse, things of that nature. These sensors that are being deployed and put onto workers in a variety of settings is being accelerated by things like the pandemic. So this is a very important time for the profession to step up and to explain how important and how critical we are to society. As I mentioned earlier, throughout the pandemic, we have worked very closely with the CDC, with NIOSH, which is the occupational research arm of the CDC. They are the ones that do research on a variety of workplace hazards, and they have a very robust respiratory protection department. And of course, OSHA, which is the Federal Regulatory Authority for Workers, and the Department of Homeland Security. They have a division called the Cybersecurity and Infrastructure Security Agency. And I put this on the slide because back in the summer of last year, AIHA was successful in getting industrial hygienists or occupational hygienists classified as what are called essential workers. So that allowed our members to be earlier in line to receive the vaccine once it rolled out at the beginning of this year. And getting ourselves identified as a essential worker is a very significant development for the profession. I'll mention very quickly that we have a lot of different associations around the world where we work together. We have developed communication pieces. We have worked together on webinars. We have put out press releases. We have provided subject matter experts that have gone to these other organizations and provided their expertise. As an example, we worked very closely with the American Dental Association last summer. They had some questions about the reopening of dental clinics and how dentists were going to be able to work on their patients with respect to aerosols. You know, when you have your teeth cleaned, you're doing work in somebody's mouth, you're generating a lot of aerosols, and that obviously creates an opportunity for virus transmission. So what types of engineering controls, for example, what types of controls in the dental clinic needed to be put into practice to reduce the ability for the virus to transmit? So that's the kind of opportunity that AIHA members had in working with our counterparts at organizations like the American Dental Association. Let me switch over to the more general topic of international engagement. Andre and I have known each other for the better part of the last 5 years, and we are very proud of the relationship building that we have developed around the world. We do focus most of our international activities currently on these 6 regions that are noted on the slide, but we also have a microgrant program that we're very proud to sponsor. About $25,000 a year is allocated towards these microgrants, and these grants are basically available to third-party organizations that are doing work in industrial hygiene in emerging economies around the world. The opportunity to apply begins now through the end of the year, and there is a committee of our members that reviews the applications and then recommends the awards of these small microgrants to the board of directors in February. They get approved, and then we distribute the monies thereafter. So AIHA, is a US-based organization. We do as best as we can with global issues, but we're not an international federation. But we do reach out, and obviously having myself and my colleagues on this call presenting this morning demonstrates our commitment to broadening our horizons and providing our expertise and assistance to other countries. I'm going to wrap up very quickly by talking about a very special project. The AIHA received a grant, which is free money, basically, from the US federal government, from the CDC, the Centers for Disease Control. This grant, we applied for the grant last year, and we got notice in February of this year, and the grant consists of 4 different projects. You can ignore the letters after these projects. Originally, we had proposed A, B, C, D, E, F, G, and it turned out that the grant scope was reduced to these 4 projects. But very quickly, what I want to mention to you all is that all of the deliverables that come out of this grant project are all going to be focused on end users. There's going to be a series of video recordings. There's going to be deliverables in terms of online tools. There's going to be an online risk assessment tool that you can use to decide whether or not your workspace is considered high risk or low risk, and what do you need to do if you're high risk or low risk. And there's going to be other resources that are going to be rolled out over the next 6 months. So you will be hearing more about these resources between now and the end of the year. And it will be an ongoing communications plan to really get the word out about all of these tools and videos and booklets that are being developed, all free of charge under this particular CDC grant project. I'm not going to spend much time covering the specific details of these projects, other than to say that, again, the focus of these deliverables is on smaller sized businesses. And as you look at these slides later, you will see that there is a theme that runs across all of the projects. And that, again, is clear, practical, common sense guidance that is delivered in language that small business owners and managers will understand. Okay. And finally, in terms of this grant project, we will be developing a communications plan, and the communications plan will be measuring how far we can reach with these deliverables. How much can we do to get the word out about these resources across the US and around the world? What actions are individuals taking in response to receiving and watching or viewing these deliverables? And then what kind of sponsorships and endorsements will we be able to recognize with respect to these deliverables? And there'll be a series of metrics that we put together to measure how effective our marketing strategy is. So a lot of very, very exciting developments, but I think my time is up. So I'm going to stop here, and thank you very much for your time and attention.
Larry, we probably cannot hear the applause, but I'm sure that the public appreciate very much your great presentation, very interesting. We expected some questions from the audience, and the questions will be through me, so I am receiving them. But nothing yet. Probably people are still trying to digest what message we are sending to them. However, I have a question, but very briefly, because we are already kind of a little bit out of the schedule. Nevertheless, AIHA did a lot of very interesting, performed a lot of very interesting projects. Have you ever tried to evaluate the business case, the metrics of the final efficiency? What was it? Saved lives, the economy impact on the organization you did, professional development. And I understand it's a very difficult question, but I just wanted to ask you, because for people it's interesting. Industrial hygienists, it's always a question of business case. How, what is your return on investments on each individual workplace of industrial hygienists, but also at the level of the organization?
So a very quick response to that question is that the demonstration of the value of our profession is something that AIHA is very actively working on. And to your point, Andre, the value is going to be very specific and customized to the industry that you are speaking to, right? If you're working with a restaurant versus a remote oil rig, for example, the value proposition is going to be very different. But one of the things that I want to communicate and leave with this audience is how important it is for our profession to speak clearly to people that are not like ourselves. How we communicate our value proposition, how we sell ourselves, and explain the role that we play in helping businesses solve real-world problems is something that we continue to evolve and develop as an association.
Larry, great. Thank you very much for your presentation and for this answer for my question, but we expect more questions from the audience during the session. Thank you. And
Спасибо большое.
Dr. Michael Larrañaga. Dr. Larrañaga is board certified safety professional, board certified industrial hygienist. He is a fellow, so it's very honorable position from the American Industrial Hygiene Association. He also is president and management principal at the organization named REM Risk Consultants. And the topic of Dr. Larrañaga today is climate change impact on occupational health of workers. I would like to emphasize that we will have two presentations on climate change and the impact on the remote locations. Very interesting. This is kind of another important topic that is on the intersection, overlap of epidemiology, of the environmental science, the industrial hygiene itself, all science about remote healthcare. So what's going on with the climate change for the occupational workers? And Michael, I'm very honored that you joined this session. And please, it's your 15 minutes of presentation, 5 minutes for questions. Thank you.
All right, thank you, Andre. I appreciate it. And I'm very happy to be here with you today. I wish I could be there in Tomsk. I did not know a lot about Tomsk prior to being invited to this, but since then I've learned a little bit about Tomsk, and it seems like a beautiful and wonderful place, especially during the summer. So maybe sometime in the future we'll see you in Tomsk.
Sure.
Today we're going to talk about climate change and its effect on workers from a very macro level, because we've kind of seen some climate change effects. It's going to happen with regards to climate change is going to happen at least sometime in the future. So in many ways, we're using foresight to try and determine what the industrial hygienist needs to know in the future and needs to be prepared for. And then also, what the workers are going to look like and what types of workers we're going to need. So I like to start out with this because one thing that the pandemic did is that it really allowed us to rethink work. So prior to the pandemic, we were a little old-fashioned all around the world with regards to work. During the pandemic and likely after the pandemic, we now can do a lot of things remotely that we wouldn't probably have done prior to the pandemic. So what it's done is it's given us permission to rethink work. Now, I have a little bit of experience working in remote locations. This is the Karanjukur Dam and hydroelectric power plant in Iceland, where I worked for almost 2 years. This was a very large project, and at the time, I think it was the largest construction project in the world. And it also involved the digging of 40 kilometers of tunnels through solid stone. And so this is a very interesting project for me personally. We did have a lot of challenges, and unfortunately, we had several fatalities and severe injuries during the project. Now, one of the interesting things about this, a very remote location, not nearly as remote as maybe some areas of Russia, but fairly remote. And the workers were Italian, so the laborers came from Italy. And so there were some issues, or I guess challenges associated with dealing with Italian workers, and especially many of the engineers were from the United States and Iceland and Canada and Germany and other parts of the world. So very interesting project for me. That dam was built specifically to support hydroelectric power for smelters in Iceland. And I also worked on this project, which was the Alcoa smelter, which is now Rio Tinto. So it's also fairly remote in Iceland, although not quite as remote as the dam, because you can see here it's on the ocean. It's in a fjord here. So one of the challenges we're going to have in the future is rapidly changing population patterns. So if we can see now, in 2007, there were 19 megacities in the world, with 13 of those megacities on water. Now, megacity is a city with 10 million people or more. Okay, so you can see Moscow here, back in 2007, had about 10.5 million people. And back at that time, it was anticipated that by 2025, we would have 26 megacities with 7 new megacities. What's happened, it's not even 2025, and we have 33 megacities around the world. So that represents the bulk of the world's population. if we can see here, these 33 megacities are mainly in Asia. And of course, we would expect that because the two most populous countries in the world are in Asia. But and they're expecting another 6 megacities in the world by 2030. So what that tells us is, in the future, a lot of our labor for large projects and remote projects is going to come from Asia and likely even from Africa and South America. And we can see that in Russia, there's 1 megacity, Moscow, right? And so it's very sparsely populated compared to Asia. But you're fairly close to Asia, so it would make sense that many of your workers would come from Asia in the future. Now, one of the aspects of climate change is that it makes existing things worse. So we know that we have warm days and cold days. We know that we have drought, heat waves, fires, and precipitation. What climate change does, it makes these things that we know very, very much worse. And so we can see this year alone, fires in Greece. We saw 2019 fires in Siberia. We saw the last several years in the United States, massive fires on the West Coast and in Canada. And so we see that, you know, climate change just makes things worse. Look at this image here. What this is showing us is the things that are necessary for humans to survive: food, security, economy, infrastructure. And here, I can't see. Oh, excuse me. I'm trying to move my health, right? And water. So we need these things as humans to survive. And if we can see that these climate change hazards, which we're relatively familiar with because they happen all around the world already, can cause disease, right? So at least 10 of those hazards on the left can cause disease. At least 9 of those hazards can cause conflict. And at least 9 of those things can cause damage to air quality. 8 can cause death and lead to pathogenic disease, mental health, and even vector-borne diseases. So we can see all of a sudden that these climate change hazards, which we're very familiar with, can cause these types of things. And matter of fact, what's listed here are impacts that have already been observed around the world due to climate change. So these are things that have already happened. And what we can expect in the future is for these things to get much worse. And because climate change is a threat multiplier, it makes things worse. Now, along with making things worse and making a threat multiplier, we have 2 acronyms here: turbulent, certain, novel, and ambiguous, or TUNA, or VUCA, volatile, uncertain, complex, and ambiguous. These 2 acronyms kind of describe the same thing. If we look at COVID-19 and the pandemic, we can see that COVID-19 fits these 2 definitions very well. But in the future, we will see that climate change impacts fit those definitions too. So what does that mean from an industrial hygiene perspective? It means that as industrial hygienists and occupational health professionals, we need to be better trained to deal with these types of things, to anticipate and recognize what the future may hold, right? And so we've seen these things already, and just talk about a few things. Increased ambient. A great example of this is the World Cup, the Qatar World Cup soccer stadium that is being built for the 2022 World Cup. Almost 6,000 people have died, most due to heat stress, most due to an increase in temperature. And so we can expect in the future that we will have significant severe injuries and fatalities from increased temperature. Along with increased temperature come, air pollution, ultraviolet radiation. So we could expect an increase in certain types of skin cancers. It will have extreme weather, which can lead to more acute hazards or acute injuries and deaths. And then what we'll have is we're going to have industries that are changing and emerging technology. The world is going to change very fast from an industrial space, and we're seeing that right now. A good example is batteries. all kinds of technologies and industries are ramping up around batteries as the center of those industries, because batteries are getting so good now, we can do all kinds of things with them. So we can expect that to happen, although we may not be able to predict what they are. We know that they were going to happen. So new technologies are going to come, and they're likely going to be much more helpful in helping us do our work and protect workers. Now, along with this comes some certain threats, and eco-terrorism is one of these threats. Now, this is the Karanjaka project that I talked about earlier. This is the dam, and you can see here a person has chained himself to this big dump truck to prevent work. And then you can see here people protesting, although they're not doing anything to stop work, they're protesting. In the future, because we expect to be much more conflict, we can expect to be sort of eco-terrorism associated with our projects, especially large projects that impact the environment. And this includes remote work projects. And these projects here are fairly remote, yet there's people there. We can expect this to be much, much more impactful in the future. And this is the Alcoa plant. And we can see here a person up on the crane. And me, I'm scared of heights, so you'll never see me up there. But we can to see this type of activity more and more with remote work. Additionally, with remote work and climate change and remote work, we're going to see a lot of opportunities. And I think this is something that doesn't get talked about enough. Usually it's the doom and gloom, and everybody tries to kind of focus on the bad things of climate change. And certainly there will be bad things, and not to take any emphasis away from those, but there will also be amazing opportunities. There will be new types of jobs that we have not yet imagined. And these will likely occur in remote locations also. We'll have new technologies that allow us to do new things. We'll be able to use artificial intelligence to solve problems. And although we don't know what those solutions might be today, we know that we're going to get there. Another opportunity, and Russia is going to be a big benefactor of this, is we're going to have new areas of exploration. Areas that previously could not be explored are going to be open for exploration, and that's going to bring with it new economies and new jobs and new opportunities for a wide number of industries and countries. Previously uninhabitable areas will become habitable. So those are a lot of good things that we can expect out of climate change, and I think we don't talk about those enough. Now, with respect to climate change and remote work, because we're going to have new areas open up that we previously could not access, remote work is going to be further isolated, at least for the near future, and far from civilization. You're going to have to do multidisciplinary roles, and I think a lot of remote work already understands this. For example, if you have a fire, it doesn't matter what type of worker you are, we have to put the fire out because nobody's going to come help you. Urbanization and the increasing move to large cities will make it difficult to find qualified employees. Now, I've also done some work in China, remote work. And when I started first going to China in 1996, the countryside was bristling with activity, lots of people, lots of farming. When I went back as early as 2006, the countryside was empty. Most people from the countryside had moved to cities, and China had built large cities to accommodate these people. But I don't think that's just isolated to China. It's happening all over the world. It's happening here in the United States. This will result in labor shortages and make it difficult to hire workers for remote work. And I'm sure you guys have already come across this. Hazards will be VUCA. They'll be new and emerging, and we might not know exactly how to deal with them. And we'll have to be trained and willing to deal with them, much like we have the COVID vaccine. And I'd like to think that industrial hygiene has been on the forefront of getting not only the United States, but the world through the COVID crisis, right there along with the medical professionals. We're going to have new jobs that we don't know what they are. Who would have thought that the government of the United States would hire people to monitor Wikipedia and, do things like that just to make sure that the facts in Wikipedia were correct with regards to government activities. So in the introduction, we talked about risk assessment. Risk assessment will become increasingly important. And one of the reasons is because employees are going to demand it. Employees are becoming smarter. They're becoming more informed. They know their rights because they all have access to news and social media. And so they are going to expect better treatment in the workplace and safer workplaces. And
My
so with that,
apologies.
yeah, I'm right on time. Yeah, so with that, thank you so
Very good.
much. And I look forward to answering any questions that you might have. But one thing, if I could accentuate, there will be lots of opportunities associated with climate change, in addition to challenges. Thank you.
Michael, thank you very much. I appreciate it's very interesting. So we still don't have anything from the audience. Potentially they will send us questions later, so we will be able to direct them to you. And it would be interesting to for us to answer by email communication or some other ways to communicate back to our audience. Still, I have a question. In 2009, as you know, National Academy of Sciences of the United States developed a paradigm of the risk assessment specifically recommended for government. And they said that it should be a cycle in 4 steps: hazard identification, exposure assessment, dose response, and risk characterization. It sounds a little bit specific for quantitative assessment of health conditions of people. But do you think that this paradigm could be applied to the situation of climate change and specifically for remote workers? And we can kind of try to direct governments, not only in the United States, meaning government agencies, but governments around the world to step by step evaluate what's going on to happen.
Yeah, that's a great question. I think I'm familiar with the National Academy's risk assessment, books and methods. I think those can be applied, and I think they are applied already, and they've gained a lot of traction. I do think they'll be useful in helping governments assess risk and with decision making associated with those things. Now, of course, one of the aspects is you have to apply the methodology correctly, and so that's and then one of the other challenges is, risk is relative. So one country or one organization might perceive risk as one way, and you or I might perceive it as another way. So that's always a challenge, and risk also is cultural. So different cultures assess risk differently. So I think it can be, but then I think there's some probably challenges to get it systematically applied around the world.
Great, thank you very much. This is what I anticipated, and it's great answer from your point of view. Thank you very much, Michael. Our third presenter is Mr. Benjamin Woodrow. He is also board certified safety professional, and he is board certified industrial hygienist, but he is also a paramedic. And our audience, many of our participants in the conference today are paramedics or people working with the paramedic expertise. And Mr. Woodrow works for Chevron North America, specifically he's health and medical advisor in the Gulf of Mexico operations of Chevron North America. Chevron, it's a great international company. I had chances to collaborate with some of the branches of this company in the Republic of Kazakhstan many years ago. And so it was great for me to listen and to hear news about the progress for this company regarding remote workers. And the presentation that we expect today is very, very interesting. And the topic is offshore COVID response and health assessments. Benjamin, please, thank you very much for joining us today.
Hello, thank you, Andre.
Mhm.
Just an audio check real fast.
Yeah.
Okay,
Sounds good.
I'm seeing myself on the shared screen here. You see my presentation okay?
I do, but I don't. Okay, yeah. Sure.
Hold up now. All right. Yeah, thanks, Andre. Thanks, everybody. It's an honor to be invited and to present, although virtually, like others stated too. Hope to be there in person as soon as next year. So maybe this will set the stage of what we can continue on and hopefully talk about maybe the end of the pandemic and how we learned and apply our knowledge to future epidemics and hopefully,
Mhm.
mitigate, from getting any bigger into the actual pandemic. So thanks again for the opportunity. Just going to share our stories like what Andre said. Larry set the stage very well with the IHA background. I'm a member of, like Andre said, industrial hygienist for about 10 years now. I've been in this role as the medical advisor and lead for the Gulf of Mexico. So just to give you an idea, in the Gulf of Mexico, we mainly operate now the state of Louisiana. My main base is in Covington, Louisiana, which is outside of New Orleans here. But most of our assets are called deep water assets now. It's in the deep water, unlike the shallow water, where we have production platforms that are mostly floating and tied down to the ocean floor, and we produce the oil back to the shore. But of course, we have to start with drilling, exploratory before that. So it's a lot like situated like cruise ships offshore, and as y'all are familiar with, but I'm not sure exactly what type of assets you have there in Russia. Most of our facilities will range from about 60 people on board some of the smaller facilities to about 200 people on some of the drill ships or some of the drilling rigs. And as you see the distance here, which involves our team from the medical and IH perspective, and the challenges, especially in remote environments, is the need to plan in advance. We're not out there, we're sitting in the office or at home now. The operators are our voice and ears of the facility, and we really have to engage with them to understand and make sure that they understand what we expect and what we need to make sure that they're working safely and the environments are healthy for them to work. We do have internal aviation where we fly our workers offshore and inshore. We have boats that service and bring supplies in and out. But if somebody gets sick, just like COVID, which we're talking about today, we would go from operating one medevac a month to more than what anybody would expect these days. And we'll go further into that. But you can see the distance that we're dealing with from the heliport to one of these facilities could be up to 100, 120 miles out, which makes a round trip medevac of 240 miles or 4 to 5 hours to get that person back to the hospital. On a daily basis, we're operating about 1,000 people offshore. So you can see the potential that we have and the high risk with more and more people. I think Larry stated it, where we have to make sure that any safeguards we can apply, we do to prevent that infection, whether it's COVID or flu or other respiratory infections offshore, to then further prevent any type of spread. So early on in the pandemic, we wanted to mitigate any of those potential spreads or from getting out there, but we really didn't have the research or the like testing capabilities early on. We did implement all the safeguards that we thought we could, you know, from daily or pre-flight test screening, such as medical screenings and temperature screenings. We know temperature screenings don't catch much unless you get very sick. And then it is the reporting culture that, you know, you ask somebody if they have a sinus strip or a headache, they don't know that it could be COVID, so they may deny it just so they can get off to work. So it's been a challenge from the beginning, but we've been able to implement some of these safeguards and increase that reporting culture. A lot of things that we worked on early on was identifying cleaning schedules, disinfection plans post positive case. One of the biggest safeguards that we wanted to get to was pre-flight testing, but early on, when we had a patient present with potential COVID symptoms, we would have to fly them just like a typical medevac, cardiac, or any trauma patient to an emergency room to hopefully see that they meet the criteria to test them. Sometimes being up at midnight talking to hospital staff and management to convince the emergency room doctor to write an order to test them. And it wasn't the end there. We still had to wait early on 3, 4, 5, 7 days sometimes for those results. And as y'all probably may have dealt with too, is what do you do with those facilities that the individual came from while you're waiting on those results? So we quarantine them in place. We maintain operations and we monitor until we get the test result back. That was early on, although it did evolve. It was quite challenging from the beginning. Luckily, since then, we were able to identify the need to make sure that any positive case was caught before they went offshore. So we implemented pre-flight testing. It still wasn't a quick turnaround at that time. It was still two days. So we had to put those individuals in a hotel until we were able to get the results, and we didn't want to mix them with anybody. So we had to manage that with security, make sure we fed them, cater, provide them with, recreational things to do in their rooms so we weren't bored, monitor, mental health, different things like that. So we knew that was a burden on the employee well-being and the organization. So as we found quicker testing strategies or opportunities to get results faster, we jumped on it as soon as we could. So we went from contracting 3 hotels one time down to 1, or a 1-night stay at that time, a 12-hour turnaround, which helped. But we were still keeping people in hotels and managing that. Then the FDA authorized the Abbott or one of the molecular tests, and we took advantage of that. Before it was available to us, it was only available to emergency rooms and those test kits. If you could easily obtain the test equipment because it's nothing new there. It was just the test kit and the cartridges challenge. And now we're seeing, more and more manufacturers developing that too. But we weren't just leaving it up to testing. We made sure. One thing I missed on the previous slide is each of these facilities, we do have offshore medics on each of those. So they're the ones responsible for implementing the offshore response plans. From the beginning, it was, like I said, it was hard to improve the culture of reporting. But whenever somebody did report potential signs or symptoms, we wanted to get them isolated as soon as possible, because what we knew about the virus at the time, the more symptoms you have, the probability of being more contagious, like any other virus. So the quicker we were able to isolate them and contain it, hopefully decrease that spread, because you're in a really close net environment there. So that's still our goal. We've been able to manage that to the best of our ability. And then as it evolved, we have changed from that one night quarantine or testing results to that rapid or 15-minute result. And we've added additional testing, serial testing behind that. So you get the pre-flight test, you get a 3-day retest offshore, and then now you get a 6-day retest offshore. And those serial testing is where we're catching most of our positive cases. So it is working, but we are still getting people to report symptoms early. And that's our goal, to hopefully, minimize spread at a facility if it does get out there. And then to add on the safeguard of vaccines, we talked about the hierarchy of controls, and we stressed that, vaccines are our highest engineering standard to prevent it. So we're increasing those vaccine rates by education and trying to explain or get to know some of the vaccine hesitancy issues too. But from an IH perspective, my background actually since high school has been a paramedic, and then I got dragged into the safety and health field after a few semesters of pre-med, and but I enjoy it. I see the proactive and then the reactive, and I think that's helped, especially during this COVID pandemic, to identify my offshore knowledge of operations has allowed me to really understand what they're dealing with out there, what their capabilities are, and what their challenges are. And right now, what we're dealing with are challenges with kind of COVID, I guess, what's the term? I forget, but just tired of dealing with COVID and wear a mask and just the long haul of that. But we're just trying to keep up with it and do the best we can, and just keep reiterating the importance of preventing and mitigating that. But we did
Benjamin, just a few minutes left.
Good. I only got 2 slides.
15 minutes flies. I understand.
So we did get a lot of support from local and industry support representatives, where we were able to get some peer-based reviews and best practices documented and shared with others. And then the last slide here, we talk about IH. Yeah, we talk about IH, we talk about prevention, but when you really get down to the grits of it, what else can you do in an open environment? And ventilation is a high piece for preventing and mitigating infectious disease and other IH-related chemical, fungi hazards. So we put together or reviewed a lot of these articles, did risk assessments at each of these facilities, and learned a lot from it and shared with others. And they were very, very well received. And it's not just a COVID mitigation, it's for all indoor air quality mitigations. But we'll turn it over, and I think that's it.
Okay, thank you very much. It's very interesting because this is something from the industry itself, and it's very interesting to see what's going on there or at the remote location for Chevron. My question, once again, we don't have anything from the audience yet. I promised you I will get back to you with questions later, but my question for you is, so ventilation, your ventilation study, and the measures to kind of prevent the spread of disease using kind of HVAC and other approaches from the industrial ventilation. How would you rank the ventilation among other measures that you applied? Because you said vaccination is our first first line of protection. Is ventilation also a big priority from your point of view, or it's just a supplement? How do you feel? Because there are many different opinions. We sometimes
Yeah.
the studies on COVID and ventilation are inconclusive in many cases. We really don't know what do we need to do to do more ventilation or to limit it, not to make it spread around, especially potentially on the like oil platforms or ships. This could be the system where you potentially cannot fully control it. But at the same time, of course, if it's respiratory infection, if it's respiratory agent, so of course we always start with engineering control. So what's
Yeah.
your feeling? Mm-hmm.
Yeah, no, I appreciate it. That's a fair question, and it's definitely not a higher safeguard than trying to prevent it, or from the hierarchy of controls you want to implement. Usually a tiered approach, right? You don't want to just think that you eliminated the hazard and not put people in PPE in a potentially hazardous chemical environment. So I do look at it as I guess similar to PPE. If you do have that hazard in the environment, what can you do to mitigate it if it does get out there? And ventilation is one of those controls. And like I said, not just for COVID, but also for other infectious disease control and indoor air quality. So I definitely don't want to put it there alone, but it's hard to compare to other higher preventive safeguards that you can. Well,
Okay, thank you very much. BJ, we appreciate very much, and we wish you well and wish everything to be okay with your home. We know that you left your home for a few days because of the hurricane, but hopefully, and yeah, maybe our experts about climate could be made responsible for what's going on around us.
thank
Thank
you.
you
Hope
very
to
much.
meet you in person one day.
Yeah.
Thank you.
So, and really hope to see you also in Tomsk. It's really very nice city. I've been first time 2 years ago there. Okay, thank you. Okay, and so our
Андрей,
next
одну
speaker.
секунду.
And I'm
Можно
very...
я одно слово скажу? Для аудитории здесь, дорогие коллеги.
Dear colleagues, those who are connected remotely, you ask your questions in the chat, but you can come up to the microphone and ask all the questions to the lecturers. Thank you.
Very good, thank you. It's also very good. But generally, the plan was that the questions will be sent to me, and I will kind of pass them to the speakers. Okay, our next speaker, and I'm very proud that we have Dr. Anthony Harris. Dr. Anthony Harris is a medical doctor. He has a brilliant educational background. He has an MBA, he has MPH, and he works for a company named WorkCare. And this company, I had a chance to see the innovation that Mr. Harris promotes and personally participate in their testing and in invention, actually. First time I heard the presentation of Mr. Harris in Colombia, right? How many years ago was it? Like 2 years ago in Colombia. Right. It was very, very interesting, and I'm still impressed. And I am sure that Dr. Harris should go to Tomsk and just to the audience, to medical professional, paramedics, many people just demonstrate what they do with remote sensor technology for ergonomics assessment. And this is exactly the topic of his talk. It's sensor technology for ergonomics assessment, the role of innovations in remote industrial hygiene. Anthony, I'm listening with great interest. Please, thank you.
Excellent. Thank you, Andre. And thanks to everyone for the opportunity to speak to you today. I know we don't have too much time, so we'll jump right into the presentation. Indeed, all about how we can leverage remote technology, remote sensor technology for mitigating risk for musculoskeletal injuries, ergonomics, right? And what you see before you right now is our ecosystem at WorkCare in regards to how we leverage remotely our expertise in delivering care 24/7 to manage injuries. And indeed, we're doing a lot of work in the oil and gas industry. And we're going to focus in today, like I said, on how we help mitigate risk around musculoskeletal using remote sensor technology. We call it bioergonomics, right? And the reason we call it such is because traditionally ergonomics is measuring the environment to try to understand the impact to the human anatomy, right? And what we're doing is actually measuring the physiology, the human anatomy response to the environment to understand the impact that individuals are having from the work that they're doing. And we all know this is a big problem globally. The number one type of injury we see commonly in the workplace, costing billions of dollars a year in direct costs from a healthcare standpoint, and usually 3 to 10 times more than that when we talk about opportunity costs. So let's jump into it. This is how we think about our approach to mitigating risk for musculoskeletal injury. We first think differently about it, right? And when we talk about how we leverage our different thoughts around it, it's all about worker health continuum, right? Going from tertiary, secondary, and then primary prevention, and being able to leverage this technology at each level with the hopes that we're doing more primary prevention, right? Preventing injuries from happening in the first place, as we are all steeped in industrial hygiene hierarchy of controls. We obviously want to do what we can to prevent. And we talk about applying this technology to uncover hidden data. And what I mean by hidden data is simply using sensors to help understand that workers are exposed even day one of a job to work that may be risky for them for a shoulder injury, a back injury, or something similar. And so what we want to do is use this data right away to help mitigate a risk of injury throughout that worker's career, and maybe the first month, the first 2 months of their working in a job place. And just kind of our own makeup, right? I can't tell that the work I'm doing, maybe reaching overhead or pulling pipes and things of that nature, is going to cause me an issue until I have pain. What we can uncover with this technology is that I'm exerting higher levels proportionate to what the baseline of that work should be for a shoulder. And therefore, I can understand that individual's risk and help mitigate the risk from intervention standpoint. So let's talk about how we apply this. It doesn't matter if you're talking about one worker or a whole line of workers. We can leverage this technology simultaneously to do remote ergonomic assessment. And we can do this while individuals are doing their normal job. Obviously, this case in the image is a manufacturing setting, but certainly we've done this in oil and gas, we've done this in chemical manufacturing, etc., and it's all done remotely so that you're capturing data that almost is impossible to do when you're talking about working hundreds of miles away from the nearest ergonomist. And we're able to do this no matter the shape or size of the worker. We've fitted NFL players, former NFL players. We fitted petite 5'2" in stature in individuals, and we can capture that data no matter where they're located, right? And it's all connected so that you're drawing insights from the data and leveraging the data to mitigate risk at any location. And so as we talk about what the objective data is and what it looks like, it is exactly as you're seeing on your video screen now, where the worker on the left-hand side here is leveraging the technology underneath their coveralls again, in a manufacturing setting in this case, and we see their muscle activity as they're actually doing their normal job. You're seeing different shades of colors here from blue to yellow to orange to red. And the further the colors shift towards the red, the more exertion that they're enduring to perform their normal job. And so our clinical algorithms that we developed recognizes this data, uses this data in concert to understand, is this individual at increased risk for shoulder injury, a back injury, a knee injury, etc. And we can do this analysis literally from neck all the way down to the knees. And we'll talk more about that. And what we're doing even beyond just the remote sensing is then layering on AI, all right? And that AI skeleton that you're seeing now is capturing motion of the individual, as well as us capturing remotely the muscle activity. And from the concert and conflation of the two, we can draw deeper insights into the risk of workers, no matter where they're located. This technology's been around for some time, right? When I'm talking about the actual sensors that are used to look at the muscle activity, it's called surface electromyography. It's been around since the 70s. We've adapted it in the remote setting so that we can glean insight, again, without having to send individuals to go capture the data. So imagine workers using this in a suit format, shirt and shorts, and they can don the suit, go do their normal job as we capture the data. At the end of the day, they take the suit off and they're done. And we have a robust set of data around the ergonomic risks for those individuals for their particular jobs. And this data is captured at the same level of intensity that and rigor that we utilize in the clinic itself, and it has been peer reviewed in terms of its efficaciousness. And the whole goal of this is to shift us forward into individualizing ergonomic assessment. Classically, we can only glean, by doing one-offs, individual assessments that we then extrapolate for an entire line of workers. And there's been limitation in terms of the speed to do that and the resources to do that, right? But leveraging this technology, bending the cost curve, we're able to then capture a lot more data and objectify individuals at a price point that doesn't make it prohibitive to individualize our approach like we do in individual medicine. And again, we call it bioergonomics, or capturing, again, physiology of the workers to understand their risk for injury. And we deliver this in a way that allows you, the experts in the field, to capture this data remotely and apply it using simplified risk levels, right? On a scale from 1 to 12, 12 being the maximum risk. And you're able to then stratify that risk across the entire workforce at a location and understand where are your riskiest jobs, where are the hotspots that you need to attack first, and then granulate down that data so you understand, is it shoulder risk, is it back risk that's driving those higher hotspot areas. We have, I won't show you this video in totality here, but I do want to fast forward just to show you a little bit of what the data looks like. And so you can see in this example, we break down each of the job functions into tasks, and we can see the different levels of risk from hand and wrist, back strain, shoulder strain, elbow strain, the levels of risk from different types of injury for each particular task. And again, this granulates down very well to help you mitigate risk, specifically with your ergonomic interventions. And we'll talk about how we apply that, those interventions here shortly. So when we look at then our clinical expertise that we deliver, layered on top of this data, it really is profound what you're able to give to your corresponding health professionals to intervene, right? Again, classically with tertiary prevention, it's recovery from an injury. Secondary prevention is, hey, I have pain, what do I do about it, right? But now that we have this rich ergonomic data, we can, before pain ever shows up, intervene so that your workforce never experiences any deficits or any drops in productivity from musculoskeletal discomfort, as well as certainly musculoskeletal injury. And so as we zero in on what we can do with recovery and return to work, we can get baselines on workers. And we know that if, God forbid, they are injured, we know where to get them back to in terms of their baseline. If we look at then our secondary prevention, we can now remotely capture data and deliver interventions remotely, leveraging the expertise of athletic trainers, delivered through a remote platform, coaching sessions for the workers, because now we can see where the workers are in their level of risk, let's say for a shoulder injury, and coach them on body mechanics and see that objective improvement of performance and decrease risk, again, leveraging this remote sensing technology. And even something as novel as leveraging exoskeletons for improved ergonomics is objectified now, and we can measure the performance of these remotely as well. Classically, we can only, when applying exoskeletons, survey an individual and say, how does it feel while you're wearing it and while you're not wearing it? Does it feel better, right? Now, we don't need to rely on subjective data only. We can objectively show that their exertion has decreased for a particular area because the exoskeleton is operating efficaciously. And that's what, again, drives safety, drives prevention, and allows us to do more remotely. And then along with that secondary prevention, we can set limits for exertion, maybe not job rotation, although you can do that. It can be limits on exertion below thresholds that we can now measure that will produce increased risk. And so what do I mean simplistically? Have a worker go perform a job, and you know that at 5 hours of that job, the shoulder risk goes up. So you can have them perform that job for that amount of time and then rotate them or have them do other activities that then don't contribute to increasing risk for shoulder or be it back or knee injury. Again, objective data setting limits on musculoskeletal risk for injury. And then we're talking again about baselines, right? Getting a baseline on a worker, understanding their risk from day one of the job, and being able to do surveillance on that individual over time so that you're mitigating risk before that individual ever has any symptoms at all in regards to their risk for back injuries or shoulder injuries. Again, all driven by this objective data. And it's as simple as this, right? You have a worker go out, put the suit on, perform their job, and you're capturing that data remotely, and you're able to then, again, leverage this data in the way that we've discussed thus far. And at the end of the day, if you have pre-existing conditions, we can capture that as well. Let's say a pre-existing shoulder injury or shoulder pain, we can then see how the job is uniquely impacting you as a worker and help mitigate that risk because of your pre-existing condition. All things that become now possible with this remote sensing technology. I won't go through these slides in detail here, but know that the aging workforce is something we can now do something about in regards to understanding the level of risk as we get older. We know that the aging workforce has about half the capacity at the age of 65 as we did from a strength standpoint at age 25, right? And so what that means when we're talking about being able to perform a job, if we conceptualize it in this way, ability to perform a job pretty much stays constant from an exertion standpoint, right? But as we age, again, our recovery time lengthens for our muscles to recover, and our strength decreases, right? And so as we age, we need to exert more of our own capacity to achieve that job function, and we can now measure that effect in terms of increased risk for injury with this objective data. Very powerful, very effective in terms of mitigating risk of injury. And then last but not least, it's scalable, right? Because we bend the cost curve and allow you to do really deep ergonomic assessment, you can do a number of things very quickly, starting with first, setting goals for your ergonomic interventions, doing all the training necessary to capture this data remotely for your workforce with online training, and then do things like A/B testing. And that is simply testing an ergonomic solution, one against the other for solving maybe a common problem with a new tool and seeing which tool is best or which method is best for decreasing the risk for that ergonomic hazard in the workplace. And again, all done remotely so that you're making the best decision before you shell out a bunch of money, capital, for that intervention. And then you can set best practices. Now that you can measure the best way to perform a job most safely from a musculoskeletal injury standpoint, that becomes then your standardized approach to that job and best practices. And then again, as you capture worker baselines, you can move into doing actual surveillance, things that we've only dreamt of doing across an entire workforce because it was cost prohibitive. Now we can do this on a routine basis in the same way we're doing surveillance from a respiratory hazard standpoint or hearing conservation, et cetera. So with that, I'll stop there. We can get into questions because we are at the 15-minute mark. Thank you very much.
Thank you very much, Anthony. And once again, I so far don't see any questions. And I understood that people
Андрей,
are
у меня есть вопрос.
invited to speak at
There is a question coming. Yes. Andrei? Thank you, Anthony. That's a fantastically interesting presentation. I'm impressed beyond the limit. And the question is, as far as I understand, your testing is being done for standard industrial operations. Or do you take each and every worker to be tested? So my question is, we cannot change the procedure, operational procedure for the worker. For example, a person has to do this and this job, or this operation at his job. Then what is the way to minimize the risk of injury if you cannot change the way the person is doing his job? Something he has to do.
Absolutely. Thanks for that question. So what we're able to do when the work itself can't be modified, which happens commonly, we're able to leverage new solutions to see how we can decrease exertion. And that's what it's all about, right? There's three tenets of this. There's frequency, we'll start with engagement, how hard the muscles are working. Then we look at the duration. For how long in a period of time is the muscle working that hard? And then frequency, how often is that muscle having to work or fire, right? And so now we can talk about interventions that decrease any one of those three prongs with this objective data. And that in turn decreases the risk for that overexertion injury. And that could be something as simple as a new tool for that same job. It could be something as simple as improving the biomechanics of that worker. A good example is back injury risk. Bending forward or lifting. Oftentimes, individuals, when we do this testing, don't fire their glutes, their gluteus muscles. And that is a known risk factor for back injury. And so we can coach them on, hey, you're bending over, you're lifting, you're bending at your knees, but you're not engaging your glutes. And we can actually get them to do so better because we have data showing how the muscles are being overexerted in a biomechanics way. So there's a lot of different solutions that we couldn't apply before because we did not know it was an issue or couldn't see the issues. Now we can.
Okay, great. Thank you very much, Anthony. And I'm
Андрей,
very...
можно еще один вопрос?
Dr. Karpov, are we okay?
Another question, if possible. Another small, quick question.
Знаю, что
So as far as I understand, first we work on some general recommendations, but then we go to more personal recommendations. Then we can actually measure each and every worker on site. Is that right? This approach from general to more individual?
We start with the macro problems that may exist, and as we solve those, engineer out the hazards perhaps, then we can get to individualized interventions to help prevent injury. Absolutely. And that's the golden chalice, right? The surveillance piece of it that we can do now.
Yeah. I also have a
Спасибо большое.
question. We're out of time, but I still probably would like to ask.
Excellent.
Dr. Harris, so ergonomics probably is just the first step, right? It's not your full horizon, because you generally can think about measuring more parameters about human body. You can also, using the same information systems, you probably can collect respiratory information like breathing rate, other parameters like that. You can read heart, because all the methodologies, I understand, is derived from the cardiogram, right? From the cardiogram.
Absolutely. Yeah, absolutely. So this endeavor is the beginning of a cadre of sensors that we can leverage remotely to mitigate heat stress injury, to mitigate fatigue even, and we're doing so in concert with the musculoskeletal. Absolutely.
Very good. Thank you very much, Dr. Harris. And okay,
My
our
pleasure.
last
Thank
speaker for, thank you. Our last speaker for today, last but not least, as we say. So it's a person whom I know for many years already. It's Dr. Boris Revich. He is a great scientist, one of the best scientists I know in Russia. And he is a chief researcher and head of the laboratory for predicting the quality of the environment and population health at the Institute of Economic Forecasting at the Russian Academy of Sciences. He's a medical doctor, professor. He is also a Nobel laureate for his work at the climate and public health. He is also an advisor to European Bureau of WHO and UNEP, and we are really very honored and happy to have you, Dr. Revich, and your topic, climate and human health, risk assessment and prevention of disease at the remote locations. So thank you very much, and we are listening.
Большое спасибо за приглашение.
Thank you for inviting me to this conference. First of all, thanks Andrei Karchevsky, whom I know for quite a long time, since the time of his previous old job, and I'm always happy to see him in Moscow. And great thanks to the Center for Corporate Medicine that I finally have an opportunity to visit Tomsk. You have been inviting me quite many times, but I never had a chance to. But I'm impressed with your city. It's the second day I'm here, and every day I'm exploring something new. Now I think this is one of the most beautiful and nice cities in the country, and I believe it should be third after Moscow and St. Petersburg. This is incredible. Not because you are, the food is nice here that you give me all the time, but every day, every hour in Tomsk, I find something new in terms of people, architecture, food, and so on. This is an amazing city. I travel a lot around the country, but these feelings cannot be compared with anything. Not too often I feel this about some Russian cities. Some key items before my presentation. Unfortunately, I cannot be at the end of the conference at the closing meeting because I have a meeting with the rector of the medical university. There was a lecture yesterday at the medical university, and the Q&A session was quite nice. But first thing I wanted to say that it was quite right when you opened the conference yesterday. You mentioned the demographic problem in Russia that is experiences toughest time. I was very lucky. I graduated from the first Moscow Medical Institute. The faculty was called the Faculty of Sanitation and Hygiene. Now it has a different name. In Tomsk, you close this department. It is interesting thing that the head of the Department of Hygiene at Tomsk Medical University moved to Moscow, was the organizer. Then he became the rector of Medical University in Tomsk. Then he moved to Moscow and was the organizer of the Department of Industrial Hygiene in Sechenova University. And my first research work, which was a huge scandal, was devoted to social hygiene assessment of children with donor disease. Then the head of the faculty was the ex-minister of healthcare in the USSR, a person who started his career as a psychiatrist in Kazan. Then he went up the career ladder and reached the Minister of Healthcare as like Mr. Potapov, who was considered to be the best minister of healthcare in the Russian Federation. But my first work was a scandal because the parents of the person with that disease were drinking too much, and the whole study was irrelevant. But this is not the matter of my point I'm trying to make. Then I was studying the environmental epidemiology. And after the Russian Federation was established, I became the member of the International Association on Environmental Epidemiology and was included into the World Association. At that time, I was the doctor of medical sciences, as I believed I did a lot for the Soviet Union, but we still lagged behind the developed international countries. The cooperation with CDC was the project leader of the first project for children. 5 projects, this Harvard School of Health, which is the best school in the world that deals with public health. Yesterday we discussed this with the rector, especially the need to develop the concept of public health in Russia. Because in Russia we put a different emphasis on this concept. How much time is needed for a doctor to see the patient? How many beds do we need in the hospital? This is something different. Public health is something different, not just counting the beds in the hospital. Then I talked about the Russian healthcare during the COVID pandemic. The result was not funding of the healthcare in Russia these days. There is a shortage of qualified staff. The salary of staff leaves much to be desired. Then the reduction of beds in the hospitals. All this resulted in the fact that Russia holds the first place in the world in terms of excessive mortality from COVID. We are the first. This is absolutely true. In August, Rosstat published exact numbers on mortality. Epidemiologists believe that the principle of the excessive death rate is not from COVID, but from all other diseases. There are different reasons for death. that should be taken into account. So if you want to go into the details of what is going on with the demographic situation in Russia, please see the report, Population of Russia. This is a regular report of the Center of Demography of the Higher School of Economics. This center is named after an outstanding scientist, Vishnevsky, a doctor, a medic, who invited me as a medical doctor to the Economic Institute. And then academician Shatalin, who was the academic advisor to President Gorbachev. He believed that we cannot develop economy without a social bloc. So the Center of Demography was established at our institute. I was the head of the laboratory, and I'm still am. So we collaborated with the School of Economics, and our institute is still focusing on this topic of study. Right now we are doing some research for the government. We have direct contacts with the government. We are preparing a new demographic report. The difference is that there is a huge economic bloc consulted by your academician Akambekan. Our recommendation is to sharply increase the funding of healthcare. But my opinion, this will not be done. But we are researchers. We have to share our opinion. We have to state our position. For this year, the healthcare system would be reduced. This is not a secret. This is published. So next year, the healthcare system will be reduced again next year. Let's see how our country will survive considering the historical crisis and the downshift in the birth rate and the increased number of deaths of the able population. Your center is doing the right thing, dealing with the working people. The person that blessed me in the medical community to be involved into the climate change issues is a person, Nikolai Zmerov, who was the head of the Institute of Medicine of Labor. I think you have his contacts, the contacts with his institute. He was promoting the health of the working population program. This is the main task from the point of view of preserving the health of the working population, which dictate our economy. But he was not successful in all the matters. So Nikolai said, when the European Bureau of the WHO, with which I was collaborating a lot on the ecological problems, they proposed to deal with these issues of the climate change, and the year after, to my absolute disappointment, it was included into the Great Academy. I think this was a mistake. It lost its independence. He said that it is quite interesting, and at the meeting he made a presentation, and we, during the first Russian conference on climate change and health. And then after a few years, in 2010, myself together with my colleague, a wonderful infectionist, an outstanding infectionist, Viktor Maleev, we published the first book, Climate Change and Health of the Population in Russia, which I presented to the CCM. This is the second edition, which was published last year. So this is the first aspect before I...
Я украду 5 минут обеда. Андрей, но не...
but I will steal the 5 minutes of our lunch. Not your lunch, but still I want to do so. Andrei said about the risk assessment, and I fully agree that it is not fully developed in Russia. Andrei knows this well, but we have environmental risk assessment and risk management quite well developed. Unfortunately, my good friend and colleague, Professor Avaliani, died from COVID. He was the one that implemented this methodology. This methodology is published by the Rospotrebnadzor recommendations. He made a good career and joined the Academy of Sciences using his methodology of risk assessment. Unfortunately, it is quite mechanical at the moment. When the ideologist leaves, his work becomes useless. Of course, there are some students or his followers that continue his scientific work. And I believe that the potential you have in your center should give you all the opportunities to cover the wider population, like the Arctic. All shift workers work quite near the villages. Professional risk is a local risk. And Andrei was right when he said about the small groups of people that he studied. With the risk assessment, when we talk about risk assessment applying to Russia, and we discussed this with my colleague Professor Belyanin, 100,000 excessive deaths a year we see in Russia from environmental pollution. And this number was mentioned in the report of the State Council. The report was called Environmental Protection to Protect Future Generations. This is just the name. And as you believe, there are many things to be done in the future. So the third aspect I wanted to mention, this was I will talk about the Arctic. Medical University is quite interested in the Arctic. There are some proposals regarding the improvement of work in the Arctic. Arctic is the priority in our country. And when Vladimir Putin 5 years ago was participating in the conference in Solikhard, it was called Arctic, the Territory for a Dialogue, and I had so the work in the Arctic is quite interesting. So before I begin my presentation, I want to tell you that we've just published another sixth report, APCC. This is intergovernmental, not international, but intergovernmental group on climate change. And I have been the member of this group for 8 years, 2 terms. It received a Nobel Prize in 2007, together with the president of the US group, Albert Gorham. In Glasgow this year, there will be a big conference at the higher level devoted to the climate change. The position of Russia. Russia signed the Paris Treaty. I know a number of international conventions in the field of environment that Russia had signed. I had to work a lot to prepare the Stockholm Convention on stable organic compounds. I have been dealing with this for quite a few years. This is similar to Agent Orange that was used in the United States. When I was in Vietnam at the big conference, I saw this with my eyes. And Russia has a special approach to international treaties. Russia signs them and then whatever it goes. Russia signed the Paris Treaty, and according to the degree of the Russian government, they are developing the National Adaptation Plan. I saw this plan. This is not written properly without full understanding of the essence of the problem. However, the representatives of the Ministry of Health were part of the supervisory board on the first adaptation plan financed by the European Bureau of the World Health Organization. That the WHO organized using the German money. I was the initiator of this plan. It was implemented on the basis of a wonderful Arkhangelsk Medical University. Now it is called Northern Medical University. So for 3 years, this project has been implemented there. We were able to analyze the main idea, and we didn't really knew what Mr. Prokhorov was intended to do. He was not really interested in collaboration, and for many years I had to force them to, the representatives of different ministries and departments, to sit together and discuss the issue, and then we were able to reach a certain result. The students are taught on the issues of climate change, on health change, on health problems, and so on. The Lomonosov Federal University is also there. They also teach the same things, and next year there will be a regular conference on climate change and health, and there will be a different session devoted to health issues. And I hope I will be able to participate. Which is more important, the President of the Russian Federation now has the Mr. Eldar Geich. He turned to be a nice and quite adequate person. He understands what is happening, and he tries to do his best as long as his status allows him. Then Ms. Romanovskaya, director of the Institute of Global Change and Ecology, institute named after the academician that did a lot during the Chernobyl accident, and was also one of the leaders of the group of IPCC experts. You see that climate in Russia is growing compared to the rest of the world, and the climate in the Arctic is growing even faster. Climatologists deal a lot, and particularly the Institute of Arctics and Antarctics. I'm quite disappointed with the fact that a wonderful person died, a person of the Arctic health, Mr. Shapovalnikov, and I don't know what is the situation right now there. These are the data of the main geophysical observatory, where our climatologists work. Here you see what is happening in Russia, and this is what is happening with the heat waves, which is our main concern as epidemiologists, and their impact on the health. When we published our book on climate change and health, I took it and went to the Ministry of Health in Moscow. I'm not an outsider. I came with my colleagues with whom I studied and or so on. So we gathered a meeting at the higher level, and they thought I am crazy. What are the climate change problems compared to the shortage of beds, medicine, and so on? There were a lot of deaths during that period, and the were no place to bury the people, and there were critical surgical operations, and people were treated in extremely bad conditions. You will have these presentations, I will leave them, and you will have a chance to see them in more details. You see what is happening in our northern and Arctic cities, where there are 4 such cities with which we work: Murmansk, Arkhangelsk, Irkutsk, and Magadan. All the articles I mentioned are published in Russian and English. Right now we are preparing another work for publication. These are the risks to health during the climate warming in the Arctic, and I will report on those risks in the big conference in St. Petersburg. This work was done in Arkhangelsk region and the Komi Republic. We have quite good contacts with Rospotrebnadzor. This year for Canada was extremely bad. You cannot imagine what was happening in Vancouver. 45 degrees. They built some storages with ventilation, with air conditioners. They put the mattresses there, and people were just scrolling there to have some rest from this extreme heat. Siberian wax?
Ну, я могу
We
вам...
probably
Да,
should keep the session, and so we need to
да.
finalize. And I even don't know how for us to be able to listen to your full lecture. It would be absolutely great for us to hear it all. But it's
Андрей,
just timing for us to conclude. Any chance that you can go to your conclusions now, and then maybe continue during the second part of the lunch?
Хорошо, значит, я вам могу пожелать всего...
Okay, I wish you all the best. I will continue in Russian so that people hear me. But I believe that my comments were quite important for Russian audience.
The session, it was very, very interesting session, and we sure request the full presentation of Dr. Revich recorded, and it would be great for all of us to look at that. But I would like to thank everybody from American team who took part in this session. Thank you very much. Great job, guys. And thank you, Boris, for very, very interesting topic that you discuss today for all of us. I think that the session will be first step for all of us to continue implementing risk assessment paradigm and concept in different countries. It's not just United States, not just Russia, yeah, but step by step, I'm sure with such a great group, such a great community of experts, everything possible. I wish you all health and happy autumn, and then I hope we meet next year all together, maybe in Tomsk, Russia. Thank you very much, guys. Thank you.
Андрей,
Thank
спасибо
you.
большое.
Good night.
Я хотел поблагодарить от имени всей
On behalf of our audience, I would like to thank our nice friend and moderator Andrei for gathering this wonderful and brilliant team of experts, highly professional. It was extremely interesting to hear to the reports, even for people who do not have any professional education, experience, and knowledge in this sphere. Andrei, thank you very much. We will be waiting you all in Tomsk at the next conference. Thank you.
Я бы сделал предложение на правах самодератора. Может быть, мы все же пожертвуем еще 10 минутами обеда и дослушаем Бориса Александровича, потому что это крайне важно, крайне интересно и просто как бы, ну вот я думаю, что все со мной согласятся.
Я
Борис
прошу
Александрович.
извинения, конечно, я как преподаватель укладываюсь лекционно, но вот все-таки не высказать какие-то соображения я не мог. Значит, проблема, забудем слово «вечная мерзлота». Мерзлота не вечная. Ее пучит, прошу извинения за это слово, но это пучение, это уже инженерный термин при деградации многолетней мерзлоты. Вы посмотрите, она сокращается. Проблемы с инженерными коммуникациями.
We still see that there are some problems with engineering communication. What does this mean? This means that this can get into the sewage that are quite old. Everything is published and well known. This is the destruction of the road structure. Such giant companies as Rosneft and other companies, they order a specific report from the experts that analyze the climate changes, especially at oil pipelines. For me, as a specialist in medicine, 20 years ago, there was a problem how to assess the health of the population that suffers from oil spills. This is the problem that doesn't exist in any country of the world. When I wrote to my American and Canadian colleagues, they thought I'm crazy because no one would drink water polluted with, contaminated with petroleum products. I brought a group of pediatrists from St. Petersburg because in Moscow they cost much more, they're more expensive. There was a huge oil spill in Usinsky region. Gastroscopy was conducted in children and the situation was quite negative. Unfortunately, I was not able to publish those materials as I wanted them to be published. There will be a session today during this conference, but unfortunately I will not be present there on air aviation. The destruction to different facilities, air facilities and so on. I will show you a few slides later. And this one, for example, talks about the prevention of consequences of low temperatures. There was a wonderful laboratory in Moscow, the laboratory of microproduction microclimate, which developed these guidelines for low temperatures. I would like to remind you that in the Soviet Union and in Russia, they have a great school of physiologists that dealt with the low temperatures. This was at the Novosibirsk Institute by your academician Kaznachev, whom I personally knew. And respect. This is a new direction which we don't know a lot about. And when I heard for the first time in the APCC, these are fundamental problems. These are psychological problems, consequences of heat. Talking about COVID, do not forget that we are living right now in the post-COVID time, when COVID encephalitis is developing, COVID depressions. These are not international works, but there are a few Russian publications on this topic. Please look at some maps on permafrost. These are weather anomalies in 2016. This one is published in English. I didn't publish it in Russian. On the Arthrax cattle burial grounds. Then this was Siberian Vox epidemic in Yamal. The Rospotrebnadzor system was quite efficient there, and as a result, the monograph of Tatiana Popova was published discussing this situation. This is what is happening with Siberian encephalitis. This is the forecast of incidence of tick-borne encephalitis. Here in Siberia, the situation with ticks is also not so promising. This is our work together with geographers. I work closely with the Geographic Society, with the Faculty of Geography. We are good friends. These are cartographers that have amazing methods, modern methods, concerning the issues, how to provide medical care through transport roads during adverse meteorological conditions. Please look at this paper. It is very interesting. So these are the economic assessments. What will be the cost of road destructions due to the permafrost? This is the WHO project that I mentioned at the beginning. I'm already mentioned intersectoral interaction. There was a lot of money allocated for the laboratory base. This is excessive days rate regarding COVID. I also said a few words about this. These are post-COVID depressions. And that is all I wanted to tell you. I'm ready to answer any questions you might have, but again, we are running out of time, and we want to have lunch, of course.
For the presentation and the rich information that you passed to us. You stated in your presentation that the Russian healthcare will decrease. In which aspect and why? Thank you.
This is a very good question, but the answer is very long. Do you mind that we talk in person, and I will try to explain my position, because this answer is not so fast. We can talk during lunch. More questions? Okay, thank you, Professor Revich. If there are no more questions, then we see you back at 1 p.m. We have 2 sessions in parallel.
коллеги, здравствуйте. Давайте будем продолжать нашу с вами работу.
Dear colleagues, let us continue our work. Right now we are here at the session number 5, educating for remote healthcare, the theories behind the reality. The session will be moderated by Artyom Kuzovlev and myself. There will be a huge work to be done here. We will have 7 reports. Please keep the timing. And I would like to give the floor right now to Artyom Kuzovlev, director of the Nyolashevsky Research Institute of General Reanimatology. Hello, dear colleagues. It's morning in Moscow right now. I'm glad to welcome you, all the participants. But I would like to ask the organizers to switch off the translation, because I cannot talk like that, hearing the translation at the same time. I'm welcoming the participants and online guests. Today we will have a very important session, training for remote healthcare, the theories behind the reality. And I think the reports will be very interesting because the speakers belong to different associations from Great Britain, from Russia, Italy, and this means that there is a lot to be discussed in terms of educating for remote healthcare. So since we don't have too much time, I suggest we get to the reports. Please remember that you have not more than 15 minutes for your report and about 2 minutes for the Q&A session. And I think organizers will support us if some of the online participants has a question. We can collect them and then discuss them at the end of the session. So we shall open our session with the first report by Professor Andrew Lockie, Vice President of the British Resuscitation
and theories behind reality. Доброе утро. Спасибо большое, что дали мне возможность выступить на этой конференции. Для меня большая честь
healthcare. And in particular, I'd like to talk to you about the theories behind the reality and why we actually teach as we teach. My name is Andy Lockie, and my conflict of interest, I have several roles within the resuscitation community. I'm Vice President of Resuscitation Council UK, and I'm a member of various committees for the European Resuscitation Council. Critically, I've been involved for many years teaching resuscitation in your country. So I've taught many courses for advanced life support and generic instructor courses in Moscow. And so I have a great affinity with the way that you teach, and I'm very, very grateful for the opportunities that has given me as well. My background is that I am a medical educationalist. So I'm a consultant in emergency medicine, but for many years I have specialized in medical education, and in particular, looking at the theories behind why we teach. Why is this important? Well, it's very important because, as this slide says, one size does not fit all. People learn in different ways. There are many people talk about learning styles, and that's a little bit controversial within the educational community because it's not really that simple. It's not as simple as saying somebody learns best by reading, somebody learns best by hearing. It's not binary. All of us have different abilities to learn over the different modalities in different proportions. So we all have different learning styles and different preferences. Why is that important? Well, it's important that when we design
teaching programs, when we create the instructional design, we need to reflect the fact that our learners have got many different needs. So we cannot just teach one way of teaching, because that may exclude a certain proportion of the learners. And in particular, when you're talking about a remote healthcare setting where the support may be online and may not be immediately available, it's important that we don't exclude those learners from important learning objectives. Within the European Resuscitation Council, we have a specific approach to education for all of our courses. And I'm grateful to my colleague, Patricia Conahan, who has also taught in Russia as well. She designed and devised this approach, this concept for an approach to education, involving 4 different aspects. The idea, so educational theories, inquiry, the research that underpins what we do, because education is not just about doing what we feel is right, it's what we know is right from the research. Implementation, so looking how we take the research and translate it into actual teaching, and very importantly, looking at the impact in terms of the educational outcomes, and also with clinical education, with the outcomes of patients. But for this talk, I'm going to focus on that top left quadrant around educational theory, to attempt to explain how we learn. So what do we mean by educational theory? As you would expect, it isn't simple. The scientific study of human learning using educational psychology dates back over 2,000 years in Plato. And over the intervening years, and in particular over the last 100 years, many different educational theories have been proposed. And these explain the application, the interpretation, and the purpose of learning and education. So there are many, many different theories that you will hear about that have been developed all around the world. In essence, we can probably split these into 3 broad categories. So there are the theories that are teacher-centered, otherwise known as pedagogy. There are the theories that are learner-centered, otherwise known as andragogy. And recently described are the theories that are learner-led, known as heutagogy. The majority of theories fall under 4 broad approaches, namely behaviorism, constructivism, cognitivism, and connectivism. And these theories overlap because they all describe similar approaches to learning, but with different emphases. And this is a diagram that I proposed a couple of years ago, which shows the connectivity between these various theories. So the behaviorist theory and the cognitivist theory are 2 ends of a spectrum, and the overlap between them is detailed by the constructivist theory, and in particular there's the social constructivist theory applicable to resuscitation courses. And then right in the center is the connectivist theory. And I'm going to talk in a little bit more detail about each of these theories so that you can understand why they are relevant to how you teach healthcare in remote settings. So first of all, I'd like to say a few words about behaviorism. So the behaviorist theory was proposed primarily by Skinner back in the 1950s and the 1960s. This is a classically pedagogical approach. In other words, it is teacher-centered. Think back to when you were at school. Rows of children in a classroom with a teacher at the front of the room. The teacher is telling the children what the facts are. The teacher is telling the children what they need to learn. The students, the pupils, They are like blank canvases. In other words, they need to absorb all of this new information. So in this particular approach to learning, the learner is passive and the teacher is in charge. And it's defined as a change in behavior in the desired direction. And the principle behind behaviorism is the use of positive and negative reinforcement. So you'll notice as well, Pavlov is one of the inspirations behind behaviorism, because the experiments that Pavlov did used positive and negative reinforcement. And that is classic behaviorism. There are many advantages to this approach, is to master the various steps before moving on to the next steps. The disadvantage is that negative reinforcement may be needed, in particular with adult learners who already have pre-existing views. But there are many ways in modern education that we still use behaviorism. Behaviorism has gone out of vogue mainly because educationalists prefer andragogical approaches to learning. But behaviorism is not all bad. There are still great advantages to behaviorism, and particularly in time-limited circumstances where you need to be able to transmit information for learning in a direct way. But I'll come back in a few minutes to talk about how that impacts upon remote healthcare. Moving to the other end of that spectrum is cognitivism. And this was devised by people including Ausubel, Piaget, and Bloom. And you see here, the definition here is that cognitivism is something that focuses on the processes involved in learning. This is an andragogical approach, so it is learner-centered. The learner is the focus of the learning in this, and it really looks around the process of how they learn. It's the use of cognitive tools like insight, information processing, use of perception, and use of memory. And it involves the acquiring, storing, and retrieving of information. In essence, the teacher facilitates the learner to learn how to learn. So it's quite complex, but it is really good in situations where there's a need to process and retrieve information. But this is a process of learning that cannot be observed directly. Moving on to constructivism, another andragogical approach, learner-centered. And this is really where a lot of healthcare education is based, their own understanding and knowledge through experiencing things and reflecting on those experiences. It allows students to work together, and it helps with their self-confidence. And they can bring their prior learning to the classroom, the behaviorist approach. So it allows different expertise to contribute. Some people prefer just to be told what to do, and so they may get frustrated with constructivism. And in its purest sense, constructivism, the teacher should be totally passive, which may be a problem if there are time limitations to the learning event. Finally, and most importantly for remote learning, is connectivism. And this has really taken flight over the last 15 to 20 years with the advent of the internet and social media. This is where the learner is heutagogical, it is learner-led. So essentially, it's where the learner can go to seek out the learning themselves. They can use the internet, they can use social media, they can use blogs and vlogs, they can talk to their colleagues. They don't have to be sat in a classroom. They choose what they learn, when they learn, how fast they learn, and where they learn. So they have complete control. Obviously not good for learners who prefer direct contact with teachers, but this really is the future of education at the moment. So how is this relevant to remote healthcare? Well, as I've mentioned, the various different approaches there are various aspects such as lectures, repeated practice, rote learning that reflect behaviorism. And a lot of simulation training reflects behaviorism. It uses positive reinforcement, you did that well, or negative reinforcement, you made a mistake, let's go back and start again. So there are positives to behaviorism that we use in healthcare. A lot of healthcare education uses constructivism, as I already suggested, like shared learning, briefing, debriefing, and simulation, and feedback and spaced learning. And as I've just mentioned, connectivism has really added value to education, and in particular in remote environments where you cannot get the teacher to the student, connectivism really helps support the student to drive their own learning. So in summary, that's been a very rapid journey through 4 important educational theoretical approaches. Within the ERC, the application of educational theory is a core component, and we use it for instructional design of courses. The important thing to remember is that each theory has got a strength to it, and it's important to use the strengths of each theory to create that diverse framework of teaching strategies, because that way we're more likely to cover all of the learning opportunities for all of our course participants. Technology, in particular, has offered us exciting new opportunities, which particularly benefit those in remote healthcare environments. And the use of online platforms and connection to many nodes of information has really helped learners in those situations. So thank you very much for allowing me to talk to you today. I hope that that's been educational for you, and I wish you a very happy and a very good conference. Thank you very much.
Доклад на крайне сложную тему.
That was a very background information, which is a theory that is sometimes very difficult to comprehend, but nevertheless very necessary. I don't see any questions.
So, dear colleagues, we shall continue. The next report will be also quite interesting, especially in the modern time. It is called Simulation Medical Training from the Perspective of Evidence-Based Medicine. The report will be made by Artem Kuzovlev, head of the Negovsky Research Institute of General Reanimatology, Doctor of Medical Sciences. Artem, you have the floor. I'm glad to welcome all the participants. I will try to slightly reduce my presentation in order to fit it within the agenda. Do you see my presentation on the screen? Okay, thank you. Within this session, we are quite successful in discussing simulation education within remote healthcare. But we try to discuss it from the position of evidence-based medicine. We will hear the position of the General International Board, the European Association of Heart, that are quite similar. Of course, the basis was laid quite a long time ago, in the 50s, by the outstanding scientists Migursky and Sakharov, that jointly came up with an idea of resuscitating people and formed the foundation for educating the medical people in this methodology. Right now, at present, there are different recommendations on the resuscitation. In my report, I am based on the American European Resuscitation Council, and on their guidelines. So this is the education for resuscitation, and I'm telling you. If you really want to know more about resuscitation and how to educate for resuscitation, please read these guidelines. They are quite useful and interesting. There is no evidence for all the items within the resuscitation focus. Since it is very difficult and the research itself is quite complicated, it is a well-known concept that if we want to increase the survival rate of our patients, this shall be all the elements shall be united into one block: education, implementation, medical science. All combined together will increase the survival rate. Talking about different educational theories, we say that we use the elements of various educational theories, different teaching methods. And it's very important to use a blended approach or a mixed approach adapted to a specific audience and to a specific case. This is the basis for the modern evidence-based medicine. There are 5 fundamental principles that we need to follow that are key and critical in educating for resuscitation, especially in remote healthcare facilities. It is clear that all experts should possess the basic knowledge on resuscitation. A very important aspect is applies to non-medical professionals. This is easy, this is simple, this is acceptable, easy to teach and easy to accept, to learn, to gain the knowledge. This is for both adult and child resuscitation. For medical workers, the set of skills is much larger. It is extended compared to non-medical professionals. There is an evidence-based framework for different target groups. If we talk about non-medical professionals, especially training for resuscitation, it is very important to work with their motivation, to teach basic things like the survival chain, to provide them with the necessary devices such as feedback. This fosters the assimilation of knowledge and accumulation of skills, which is called spaced learning in English. The education is spread in time. Like every week, 1 hour, and the assimilation of information is quite faster and more efficient. There are many technologies facilitating this process, but when we talk about the medical workers, here we need to teach specific skills like ALS, ALS, PBLS, PALS. These are the abbreviations of the European Council for Resuscitation. They are slightly different from the American Association for Heart. It is also very important that those shall be formal certified courses with simulation sessions and so on. For medical workers, it is advisable to use different checklists, tips, and algorithms, and debriefing technology. The use of algorithms has its pros and cons. The advantages include the reduction of cognitive load, the decision-making process is improved in the condition of distress and time deficit, but the disadvantages are also there. The communication between group members may be disturbed. Different schemes and algorithms can distract the attention from the main topic and reduce the quality of service. We analyze separately the recommendations published in the Elsevier journal about the effect of team and leadership training of advanced life support providers on patient outcomes. Debriefing is a very powerful tool, and there are different debriefing technologies. Debriefing shall be used both during training and in real life. If there is a resuscitation case in a remote site, we need to discuss it first, what happened. So it there are different debriefing technologies like sandwich plus delta, advocacy and inquiry, and learning conversation that is widely used in Russia. There are different debriefing stages, and this is a separate topic. Here, the task is to train the instructors, but this is not the topic of our today's discussion. All these technologies, learning technologies, equipment is embedded into the course structure. Any course, any learning shall its specific structure, and first of all, we aim at certain knowledge obtained by our students or trainees. However, there are different opinions with regard to this method. But for teaching practical skills, we use this four-stage method. Definitely, based on my experience at basic courses, in the courses for adult and child resuscitation, there are no evidence-based data that this method cannot be used. This method allows mastering the skill and using this in the practice. There are other methods, such as the rapid cycle. When you follow this circle, you give a simple skill, then there is a short debriefing, then you give a more serious task, and then they again discuss it. And this methodology was developed in by John Hopkins, and this is recommended by the European Council for Resuscitation. Professor Loginov already говорил about the importance of e-learning technologies. These are the technologies that are becoming part of our daily life. A few reports today will be devoted to this interesting topic. It is very important that this is not just a mere text downloaded to a website, but an interactive e-learning environment with tests, videos, and so on. There are more complicated technologies, virtual technologies, augmented reality, and so on. But there is no much evidence-based framework for them. Probably if there is no possibility to have offline courses, this is a good alternative. But again, we highlight all the time that it is very important, again, at least to ensure the simulation practice using the mannequin. Simulation technologies should use the simplest equipment, while there are some advanced courses where the equipment can be more sophisticated, because simple technologies allow better simulating the knowledge and master the obtained skills. Don't make your work too complicated. Teacher training is a very complicated issue as well. It is clear that we need to do this within the framework of structured courses. The European Council for Resuscitation has generic instructor course and basic life support instructor courses. And right now, they are reviewing the programs and curricula and approaches they are using. What our educational courses influence the clinical outcomes? First, these are the advanced resuscitation and remote resuscitation courses. There is an evidence-based framework and which confirms that the participation in those courses has some impact on the final outcome. That is why I extremely recommend you to pass certified courses only. Again, your training and regular retraining is the basis for supporting your practical skills in good shape. And this is the visual cycle of continuous learning from medical people. This is nothing new. We work within the system of continuous medical education. There are also some recommendations for pedagogical control. Usually pedagogical control is continuous with certain checklists and so on. And again, by concluding my report, I'm asking you, especially those that are involved in teaching, please read this section that reflects the details of all the researches regarding the training for resuscitation at the courses of the European Resuscitation Council. The principles are quite simple. Shall be a unity of science, educational technologies, and implementation of this in practice. And only the use of effective and evidence-based pedagogical tools will make it possible to improve the survival rate, including in remote industrial objects. Talking about the simulation discipline, these methods and approaches are quite the same, and you can transmit them to other courses as well. So I'm using this opportunity to invite you to the international conference devoted to the critical states and survivability that will be held in November. And I'm thankful for your attention. I try to save some time for a Q&A session and for other reports. Thank you very much, dear colleagues. Thank you, Artyom. You have access to Q&A. Is there anything in the chat? There are no questions so far. I have one question. You mentioned the European Council for Resuscitation and the guidelines that they developed. Do we have something similar, like the analog of these recommendations that we can refer to in our work? This is a very important question. Right now at our institute, we're developing methodical recommendations, as we call them, on resuscitation. Unfortunately, according to our legislation, they cannot be clinical. That is why they're called methodical. And I hope this year we will coordinate them with the Ministry of Health of the Russian Federation, and they will be approved. The issues of teaching and learning also require certain regulation. There is a committee on education, and in the future we plan to tackle this issue as well. Thank you, Artyom. We have one question from the audience. My name is Piotr Yeniseyski, health manager. Can you tell me when they will train all the medical staff in Russia using the certified courses, so that they will get not a simple certificates not needed, but something similar to European or American certificates? Why am I asking this question? Unfortunately, what is happening in Russia, they take, for example, the European guidelines or American guidelines, and then someone takes out the key points out of those recommendations. I will give you an example. In 2018, like the resuscitation was not dealing with cardiology or some other acute diseases. Someone decided that this should be excluded from the agenda. But to my understanding, this should be a very comprehensive integrated course covering all these European guidelines, so that the surgeons, therapists, all that have, so that in the hospital they will not start running around when the person has problems with the heart, looking for the resuscitologist. But the doctors any doctor is able to do the necessary measures himself. I fully agree with you. We need to develop something similar for the Russian reality that should be placed in the electronic library of the Ministry of Health of the Russian Federation. As a skill, this is included in the standard. of the Russian Federation. But I fully agree with this is an international session. I would not distinguish between basic and advanced resuscitation. The guidelines are the same. The American Heart Association and the European Council for Resuscitation, they talk pretty much about the same things. I think we need to move further and get to the next report, if you don't mind. If there are some questions, please put them in the chat box. So we shall move to the third report. The report will be made by Marina Stracha
Американской ассоциации сердца.
Of the American Heart Association, our colleague from Italy, and it is called American Heart Association Digital Transformation. Go ahead, please. Can you hear us? Yeah. We can't hear you, unfortunately. You can. Yes, yes. Please go ahead. Здравствуйте. Вам видно? Слышно? Все хорошо? Я начинаю. Здравствуйте, меня зовут Марина Страча. Она меня слышит опять? Okay, you can hear the translation, yes? Okay. И я работаю в Американской ассоциации сердца как международный консультант. Для меня большая честь выступить на этой конференции. Наша глобальная миссия — это спасение жизни. Я буду рассказывать о том, как мы разрабатываем руководство guidelines. И до того, как я расскажу больше о процессе, я расскажу, как мы разрабатываем информацию. Сначала мы исследуем уже имеющиеся научные труды, и члены комиссии ИЛКОР используют свои рекомендации и уже дальше адаптируют их для АХА, для Американской ассоциации сердца, для различных региональных использований. Мы используем формулу Эйнштейна для того, чтобы повысить уровень выживаемости после сердечно-сосудистых заболеваний. В 2020 году мы обновили наши рекомендации на основании самых последних исследований и внесли туда дополнительные всеобъемлющие рекомендации. Мы даем рекомендации для разных тренинговых курсов по всему миру. Наша главная цель — это повысить выживаемость после инфарктов. Для наших студентов и для студентов, которые используют эти курсы, которые рекомендуются Американской ассоциацией сердца, мы стараемся сделать так, чтобы самые обоснованные и доказательные подходы были использованы для Для исследований.
Programs. Our programs are built on the newest clinical science. And delivered using best practices for adult education. Students in our instructor-led training programs have the opportunity to expand their skills and practice in team simulations. Using our HeartCode and our QI programs, students are able to reinforce their knowledge through online adaptive learning modules at their convenience while regularly practicing and improving the skills they perform. The third part of the U-STEAM formula equation is systems of care. Systems of care is constructing a process to get the right equipment and the right people with the right training to the patient at the right time. Data registries such as Get With The Guidelines help organizations to identify areas for improvement in their response to cardiac arrest. Telephone CPR programs help dispatchers to coach bystanders through giving CPR to cardiac arrest victims outside of the hospital until the ambulance arrives. The 2020 guidelines also highlight the need for effective recovery and mental health support plans for survivors. Activation of willing bystanders have always been a challenge, but recent improvements in technology enable mobile phone apps to be developed that can notify responders of an event near them so that they can respond and initiate CPR before arrival of the ambulance, a practice that significantly improves survival. Finally, new initiatives are being developed to support the willingness of the public to use the AED and perform CPR on a cardiac arrest victims. Now let's focus on the American Heart and who we are and what we do. The American Heart Association is dedicated to ensuring equitable health in all communities. Through collaboration with numerous organizations empowered by millions of volunteers, we fund innovative research, advocate for public health, and share life-saving resources. The Dallas-based organization has been a leading source of health information for nearly a century. As we already mentioned, heart disease is still a #1 killer in the US and worldwide. Stroke is a leading cause of disability and #5 killer in America and #2 killer globally. The American Heart Association has been a pioneer in cardiovascular research and preventive education programs to improve health and reduce deaths from heart disease and stroke. These are just a few of our achievements in our nearly 100-year history. The past fiscal year was like no other. The past fiscal year was like no other, so no one could have foreseen the rise. And as you can see, the problems that we're facing today, nearly half of US adults have high blood pressure. E-cigarette use among middle and high school students is reaching epidemic levels, but nearly half of the US population is expected to have some form of cardiovascular disease by 2035. So the past fiscal year was like no other. No one could have foreseen the rise of the coronavirus pandemic, the toll it would take on millions of people worldwide, the impact it would have on the economy and our life-saving work, despite taking swift action to limit and spending continuing fundraising. It became clear that the American Heart Association of the future would be different in order to continue to drive and impact and save lives in this new world. We challenged ourselves to fundamentally reinvent what we do and how we provide our, and how we prioritize our work. So how are we making this impact? The impact during the COVID pandemic, as you can see, has the American Heart Association working through research, leveraging science and relationships, meeting the needs of our healthcare workers, and teaching how to safely administer CPR. We deliver life-saving programs in 100 countries worldwide. With these statistics, we all see that we translate our life-saving training products in more than 10 languages and distribute them around the world. Since 2012, we're committed to more than $2.5 million to direct global research and studies. Every year we train 22 million people globally, first in first aid, and CPR and AED every year. We develop guidelines for first aid and resuscitation training that are incorporated into our trainings globally. We offer a complete portfolio of resuscitation solutions for best-in-class education and continuous quality improvement. And we are the #1 research training provider for hospitals and emergency medical care services. Our training includes all categories that span from healthcare professionals to lay rescuers and non-healthcare professionals who need a card for job regulatory requirements, and those in general for the public who want to learn CPR. So these are some of our courses. We teach basic life support, advanced cardio life support, EP courses for experienced providers in advanced cardio life support, pediatrics assessment, emergency recognition, and we teach them for lay rescuers. We have programs for adult first aid, CPR, AED training, bloodborne pathogens, pediatric first aid. Digital transformation. So why digital right now? It goes without saying that 2020 is unlike any of what any of us would have predicted just a few short months ago. Whether we meet in person, virtually, or on a smaller group settings, we're committed to ensuring that our events continue to be safe, fun, and centered around saving and improving the lives of all. Furthermore, to meet the needs of a changing world, the American Heart Association is integrating digital technology to continue to maintain our mission globally. First of all, we need to emphasize that poor quality CPR is a preventable harm. Research has shown that psychomotor skills decline rapidly over time, and the current 2-year course completion card model does not lend itself to the maintenance of competence in CPR skills. The traditional model of training has been based on biannual training. Every 2 years, healthcare providers need to retake or renew their training to maintain their course completion card status. And then once every 5 years, AHA releases the CPR and ECC guidelines, which may include changes in the way AHA recommends that CPR be done. So there may be a refresher of content and skills required with those changes to our guidelines. Years ago, we theorized this may not be the most effective way to maintain CPR competency. You can see from this graphic that the competency of a provider decreases over time if they don't frequently practice or use their skills. We hypothesize that high-frequency, low-dose type of training solution might be more effective in maintaining healthcare providers' competency in performing what is largely psychomotor skills. So today's new challenges require innovative solutions. American Heart Association is implementing a unique and effective way to deliver safe and effective CPR quality improvement. We have partnered with RQI Partners and Laerdal and to meet the needs of the changing world that is evolving in traditional healthcare education models. The AHA digital portfolio is a methodology of teaching that combines the latest technology, latest science, high-quality CPR competence, and maximize the goal of life-saving outcomes. In the age of COVID-19, the AHA is rethinking CPR and education delivery. The AHA digital resuscitation portfolio is becoming the preferred solution to deliver safe and effective CPR quality improvement. So the American Heart Association's Heart Code programs deliver quality resuscitation training through a more flexible delivery method. This method gives providers and administrators the more control of their time, schedules, and resources. I'd like to further emphasize that the obligation of the healthcare system is to ensure that their staff is trained in high-quality CPR. This represents the needs of healthcare systems, the recognized or unrecognized problems that can be resolved by Heart Code blended learning programs. The course delivered through your organization's LMS or through RQI Partners' own RQI Stop platform. The program delivers detailed debriefing after each online learning module and real-time audio and visual feedback during skill session to ensure learners are receiving the highest quality training possible. After completing their assigned course, learners earn an HA card valid for 2 years. So first, let's discuss Heart Code. It's intended for pre-hospital and in-facility audiences. the student must complete an online portion, which includes knowledge activities, adult and infant e-simulation scenarios with debriefing hyperlinks from debriefing to BLS student manual and multiple choice exam. The student then must complete a hands-on session and testing with either HeartCode voice assisted mannequin or a live instructor or both. And once completed both portions, the student receives a completion card. HeartCode Complete learning model, the student completes an online portion which includes knowledge activities as the previous model. The student then must complete a hands-on session and testing with an RQI simulation station. And once completed both portions, the student receives a completion card. The AHA Science Statement on Resuscitation Education made the following recommendation to achieve education efficacy as it relates to resuscitation. The journey to quality must incorporate mastery learning, use deliberate practice as a methodology, establish a performance goal for both mastery and deliberate practice, use overlearning for behaviors of what is likely to decay. Okay. So moving forward, when we look at the world today, what are we facing? How do we go from this to this? Necessity is the mother of all invention. Since the arrival of the novel coronavirus, the world has adapted in a new and often incredible ways. The American Heart Association is no different, with innovative new virtual trainings underway now in many countries. So responding to the demand for continued high-quality training for CPR, AHA first piloted the idea as a means of resolving the problem of staff not being able to travel. The advantages to digital have been welcome. With an AHA expert participating via conferencing technology, we are able to provide guidance on real-time happenings in the classroom while ensuring that quality of programs is not reduced. The ability to record and play back classroom events is also useful. So going forward, the American Heart Association has included Russian translations to provide in-language courses to help the AHA training network in Russia. Students be assured, the world may change as a result of this pandemic, but the strong commitment the American Heart Association has to its programming instructors never will. The Russian translation is for the ACLS course and will be available soon and include the provider manuals, instructor manuals, course e-video, and written exams. Thank you for helping us reach our goal of a world where no one dies from cardiac arrest. Thank you. Спасибо.
Марида, большое спасибо за этот.
Thank you so much, Marida, for your brilliant report.
Если позволите, я задам один вопрос, и мы двинемся дальше, поскольку у нас достаточно много еще.
If you allow me, just one question, and that's it. What is your opinion about AHA and RQA, the new models of different online versus hands-on experience? Do you think the efficiency of the new programs, will it be comparable to the standards courses that we had in the past, or maybe it will be even better than before? What is your forecast? What is your estimate of the efficacy? Okay, so did you hear the translation? Oh, you didn't hear the translation. Okay, so let me just tell you just once again, what do you think about the efficacy or the efficiency of the new blended courses, online modules plus hands-on? Do you think they will be just as effective as the old ones or the old approach, or maybe you forecast that the efficacy of the learning this way can even improve?
So yes, I do believe that there is a benefit in teaching in this way because the training is less, it doesn't take place every 2 years. So the students or the providers are less likely to have a decay in the skills. The online portion is based on an adaptive learning system. So it is tailored to the student and the knowledge that he has. Once the student completes that cognitive portion, he does come into the classroom with an instructor who teaches him the skills, has him practice regardless, and tests them and evaluates him. So I do feel that the blended learning is beneficial to the student, and it has many, many benefits. Less time in the classroom, which is something that we're really looking forward now with the pandemic. And also, we can help those healthcare providers, which now have a really difficult time doing any kind of training, just because they're so needed in the healthcare system, working towards, even this pandemic. So there's less time to be able to train. But it's so important to keep that training up and upkeep those skills so that the high quality doesn't decay over time.
Большое спасибо, Марида, за крайне интересный доклад.
Thank you so much, Marida, for this interesting report and for your viewpoint. And it is nice to hear that all of us on the European Resuscitation Association and the American Heart Associations are moving in the same direction in terms of the educational technologies. Can you hear the translation now? Can you hear the translation now? Marida, can you hear me? Can you hear? Marida, it is nice to hear that we all are moving in the same direction, both European Association and American Heart Associations are moving forward in the same direction. The next report is called Training of Personnel for the Conditions of the Arctic Climate and Hazardous Regions. The report will be made by Dmitry Suslov. Please keep timing. Hello, dear colleagues. First of all, I would like to express the words of gratitude for inviting me to this unique conference, especially to Sergei Antipov and the Center for Corporate Medicine. I would like to briefly tell you about the Russian University of Elite Forces. And I will tell you about our experience of our expedition to the Arctic. This experience is quite unique and can be adopted to make some conclusions in remote healthcare. I'm a paramedic, a combat medic, and a mountain rescuer. And I'm a senior instructor. First of all, I would like to tell you a few words about the Russian University of the Russian Elite Forces. It is located in Chechen Republic in Gudermes city. It was established in 2013 upon the initiative of the hero Ravzan Kadyrov. This university is a non-educational institution. This is a private project, quite unique for the Russian Federation, where it is possible to arrange various and different trainings, since this training site has all the necessary conditions, equipment, and so on. The territory is 400 hectares, 95 buildings. Then we have the helicopter and an aircraft. To train different teams that provide assistance in rescue situations. This center was created for
the needs of the Russian army to train special forces. There is a medical department, and I'm part of that department. There are 10 different courses for military personnel and for civil people. So these are the training sessions where we, as the Russian officers of elite forces, participated. Like the Russian Guard officers and others that show their military functions in the Arctic region in adverse climatic conditions and remote places. The first training session was in Archipelago Franz Josef, fully autonomous, 21 days. I made this in the chronological order so that you understand the difficulty of the expeditions. The sleep hours 8, and the average temperature is 30 degrees centigrade. We need to make sure that everybody stays healthy. In case somebody is injured or something happens to health, we need to take the necessary measures or ensure evacuation. Then there was a route on snowmobiles through the Lake Baikal in winter. It was also fully autonomous. It lasted 1,500 kilometers during 5 days. Number of sleep over 5 days is 30 hours. So the employees were getting tired and needed some nutrition in certain pharmacological means that would maintain their health and strength. And the unique route was in Dudinka and Dixon Island, fully autonomous. The length is 1,520 kilometers. We did this route on snowmobiles. It lasted 4 days. Number of sleep over 4 days, 18 hours. The average temperature is 34 degrees centigrade, below zero. What is the uniqueness of these training sessions? The expedition aimed not only at military skills, training the military skills, but also it was necessary to make some conclusions by the participants of the expedition. Our task was to collect and study the information that was necessary, particularly for us, how to provide medical assistance in -40, how to avoid some traumas and injuries and some negative consequences for the body. So these are some pictures from our expeditions. This is the Lake Baikal. The food and fuel was always with us. So this is how we slept. And you see that during all these events, there were people that got sick and people that were injured, but thanks God that everything was without casualties. So the last expedition was this transition to the Dixon Island. We also simulated the icebreaker invasion, so we had to save people and so on. So it was quite interesting and challenging. Of course, I'm talking more about the expedition medicine, as we call it. Not when a medic is at a remote site at his office medical room with all the necessary means available. But I'm talking about the medics that are autonomously traveling with a group and need to provide the emergency care. When a medic is part of the expedition. There are three important aspects here. Training before the expedition, during the expedition, maintaining the health and state of people, and post-expedition. Pre-expedition training including the following: selection of people in terms of their moral and volitional qualities, medical checkups 2 weeks before the expedition itself, elimination of all the dental issues, because in case something happens in a remote place, the only way out is to remove a tooth. There is no way to treat it. Training in highlands with the temperature close to the Arctic environment. The entire group, including myself, went to the mountains where it was very cold, windy, a lot of snow. The environment was quite the same as in the Arctic. So this teaches us to survive in these adverse conditions. So a person is preparing his body, his organism for a hard expedition. Then we checked all the machines, equipment, clothes and shoes, because if something breaks during the expedition, this will again impact your health, like trauma and something else. There were some training sessions on how to render first aid treatment and training on the adaptation of a person to extremely low temperatures. Because this is very important for people to understand and realize where they are going and what might happen with them and what measures they should take in case someone is injured, or in case of an emergency, like a person is lost, how to survive along, what to do, how to burn a fire, how to hide from snow, and so on. We made a lot of conclusions. I will not tell all of them, because some of them are for military purposes only, like medical supply. What shall you do if the person is bleeding and you need to get some additional blood? How to do this in the Arctic? How to heat blood and get it to the person at -30 or 40 degrees? So we teach transfusion also in extreme conditions. Water, personal hygiene. The example with water, like when we were doing this route with snowmobiles to the Dixon Island, halfway during a day, a person drank 9 liters per day. And I was following this. If a person didn't do this, the level of his reaction and stamina would be low. When the people were going to the toilet, I was checking the color of their urine in order to understand what is happening to their health.
Конечно, с этим более подготовлены.
Again, our employees are well prepared and we know where we are working and we are ready for everything. So we have all the necessary equipment with us, additional batteries and so on. So the survival kit, guidelines for adaptation in the Arctic, and assistance in case of trauma. What were the difficulties? There were too many, of course. Many of colleagues today mentioned already some of them. Besides the Arctic environment, there were unsafe conditions. So the difficulty for such a medic that is part of the Arctic expedition, for example, or a dangerous environment, there are some negative elements, like I'm talking about humans, terrorists, bandits, and so on. some political situations can be quite adverse, or the population may also affect somehow a medic or a place of his location. So these are the major difficulties. These are some issues or recommendations that we desired for medical personnel that is going for such expeditions or works in extreme conditions, like wilderness medicine, BLS, prolonged field care, which is also very important, and some people forget about this. When under limited resources, you are with an injured person for several days and you have to do something. Telemedicine and adaptation and survival in the climate techniques. This is an example of the training session. I'm showing this to our employees, how to get out of extremely cold water. So this is a backpack with all the equipment, with all the weapons. The temperature was minus 52. Later, there was a training when the icebreaker is when moving, leaving a trace, and a person may fall down underwater easily. So this training was very useful for the guys that were part of the expedition. If this was a real situation, but if they were trained in advance how to survive in case something similar happens, they would be. They told us that they would not spend too much time and they will not be hurt or injured that much as they did. So these are the objectives of staff training in extreme and dangerous conditions. There are three major factors: psychological training, physical training, and professional training. Physical training is also very important because it affects many aspects, especially in remote locations. These are the three pillars of training. I would like to show you one short video. The 4 days, the people were. The video is very emotional and inspiring, so please have a look and you will see everything.
Как вы видите, тренинг проводится при любой погоде.
As you see, the trainings are done in any weather conditions. In December, for example, this was done in, this is the hypothermia, how to warm up yourself. The training lasts 4 days, and during 2 nights, they sleep only 3 hours. In order to create such conditions, such adverse conditions, so that we want them to feel as close to the real conditions as possible. This is this simulation of different attacks. And each trainee has an opportunity to train his medical skills. I believe this is very important and very impressive, because this trains both psychological, professional, and physical abilities of people. During this course, the guys had to carry an injured person more than 10 kilometers. So this is a physical test. It is as close to the real conditions as possible. If you are professionally ready, but if you are physically unfit, you will not be able to save a person, for example. They are doing this with medical toolkit in their backpack. Imagine that such type of help is the most complicated, because you're limited in resources, you're limited in people, the environment, the surrounding environment, it's quite adverse. That is all. Thank you for your attention. I'm ahead of schedule already. Thank you for your attention again.
Будут ли вопросы?
Do we have any questions? I have one short question. Dmitry, can you tell us? You demonstrated a video on the training of your people. Are there any Russian programs in Russia that are approved and certified training programs, I mean, and what is the potential for further development? This is a good question. Unfortunately, military medical training, at not even at a 0, but at a -0 level, compared to Western and European countries in America. Pre-hospital stage includes training and equipment. These courses, our courses, since I passed my training abroad, this is based on the international course that I passed in America. Combat Lifesaver. This is the next course, more advanced, on tactical medicine. Unfortunately, at the moment, the level of military medical training is quite low, but we need to strive for improvement. We need to send our workers abroad, but instructors, to pass their training abroad, where the advanced programs and means of training are used. Because right now we're using the obsolete equipment to stop blood, for example. So there are no certified programs in Russia. Thank you very much. Thank you, Dmitry. I think in the future we need to collaborate all together. Your military community and our medical institutions, because you're probably a very unique structure, and you will definitely help us to improve the training in terms of the first aid treatment and the training in remote locations and so on. Let's move further. Dear colleagues, we have a few more reports left.
Speaking about the programs, training programs, educational programs, today we're going to listen to Matthew Walter, who is the head of the School of Medicine, Dentistry and Nursing of the University of Glasgow. He is a professor and honorable consultant. Доброе утро, дамы и господа. Я с вами сегодня нахожусь виртуально, и я являюсь главой школы медицины, сестринского дела и стоматологии. Сегодня тема, на которую я хотела бы с вами поговорить, это разработка обучающей программы для удаленного здравоохранения. Чтобы ввести вас в контекст, я бы хотел сказать о том, что я работаю в университете Глазго, глава школы медицины, как я сказала. У нас очень хорошая репутация. Мы очень высокие позиции в рейтингах Великобритании по медицинскому образованию занимаем. Сейчас на втором месте.
To regain number one spot next year. So I'm going to talk about some work we've been doing recently with the International Remote Healthcare Association, led by Professor Nelson Norman, who many of you I'm sure will know. I lead the research and the academic subgroup of the International Remote Healthcare Association, and we have been charged by Nelson with responsibility for the development and the delivery of a curriculum for remote healthcare workers with a view to improve the delivery of healthcare to those working far from urban centres or conventional centres of medical care. The objective and the vision is for this curriculum to be evidence-based, that is informed by current practice and by the demands that we know are placed upon healthcare providers in these circumstances. It has to be compatible with ongoing evolution of remote working, so different technologies being used, potentially a different spectrum of injuries and difficulties being encountered. It needs to be fit for purpose. It needs to be credible. In other words, adopted by, recognized by agencies involved in the regulation of healthcare internationally to reflect the international context of the delivery of this care. And it needs to be delivered at high quality and also at scale, because we know the demand is significant. So a significant task for us to develop a curriculum of this nature. The challenges that we face, particularly in achieving these objectives, firstly, we know that the needs of those requiring healthcare will evolve. As I've mentioned, the technology changes, the spectrum of difficulties that might be encountered in remote circumstances. Some remain the same, but other new challenges arise, and our curriculum needs to be sited on that and able to deal with that. We know that the case mix may change with time. We know that different types of people are traveling to remote environments to work, and we need to ensure that our curriculum reflects the different age spectrums, for example, of people who might be working in remote environments and who therefore might require healthcare of various sorts. We need to be absolutely confident that the delivery of healthcare reflects the abilities that we now have and we continue to evolve in telemedicine and teleradiology, for example, which has been an increasingly important part of remote healthcare over the last few decades. And it's very likely that as technology continues to improve, robotic surgery and various other developments, for example, telemedicine, teleradiology will continue to be an ever more important part of the delivery of remote healthcare. When we consider the curriculum, we need to make sure it's properly contextualized. So, for example, the spectrum of problems that might be encountered in a very remote Arctic environment, for example, might differ significantly from those encountered on an oil rig in the Gulf of Mexico, for example. So we need to contextualize the curriculum and make sure that it is fit for purpose in whatever circumstance in which it's applied. And we also need to ensure that, as I've mentioned before, it's credible, that it's properly endorsed by appropriate international entities, and that it is robustly assessed. Because like all healthcare, what we don't want to do is to give people credentials to deliver treatment that they're not actually capable of delivering, because that serves nobody's interests, indeed is dangerous and negligent. So we face significant challenges in developing a curriculum of this nature. It's not a new idea, it's been attempted before. This is a paper dating a few years now from the IRHC, which intended to define a list of competencies that healthcare practitioners in remote environments, in this case specifically oil and gas operations, would require. Now, it was a good attempt. It's a well-written document, and certainly it's comprehensive, but there are a number of weaknesses that we aim to overcome with our new project. Firstly, this is a Delphi study. This is a group of people sat in a room giving their opinions, but this is not, strictly speaking, an evidence-based curriculum. I mentioned before that technology evolves quite quickly, and this is now a number of 7 years old altogether. So it may be that the information contained in this curriculum, which hasn't been revised or updated since 2015, is now out of date. And perhaps as a consequence of these things, this document has not been widely recognized, widely adopted, and doesn't really inform current clinical practice or clinical training. So we are intending to develop a proper evidence-based curriculum and to approach it in a scientific fashion using modern pedagogical techniques. And these are the sorts of questions that we need to address when we're considering designing new curriculum. What sort of healthcare worker do we want? So what skills and abilities do we want these people to be imbued with? What degree of autonomy should they have? How should we train them? What techniques should we be using? I think it's quite clear that there'll be a significant amount of practical skill required for these people, and lots of simulation, I suspect, will be required in upskilling and imbuing these people with the talents and the abilities that we want them to have. We need certainly to make sure that our curriculum is fit for purpose, and that those external agencies, and particularly the employers of these individuals, are engaged in the development of the curriculum and have confidence that people who hold the qualification that we propose to put in place will be sufficiently skilled to undertake the work for which they are employed. What learning outcomes should we include? And this is really the first question we're looking to address. So what are the important medical issues that we need to make sure our people are capable of dealing with? Assessment techniques are obviously evolving all the time, and we need to make sure that the assessment techniques we choose are robust, credible, and fit for purpose. And in the longer term, it's not just a question of passing an exam and going out into the field. We need to continue to evaluate our practitioners and to make sure they retain the skills that they have, and that any new skills they may require are available to be taught to them. So a large number of issues with regard to the considerations that we have as we design this curriculum. And we can look at this through a number of filters. This is one way of assessing the ways in which people learn and how we might best approach giving these practitioners potentially some new skills. So we have learning on the job, and we have classroom-based learning away from the field. We have the conscious acquisition of new knowledge through either sort of structured learning or taking opportunities in the context of employment. But we also have the unconscious absorption of new information and new techniques. And an effective curriculum should really attempt to harness all of these methods with a view to maximizing the chance of producing a highly effective practitioner in the circumstances that we want them to work in. We need also to be careful about how we integrate the teaching and the assessment. And I've alluded to this before. We need to define what the learning outcomes are going to be. We then need to make sure that we use the appropriate teaching methodologies, and that could be classroom-based, it could be on-the-job learning, it could be simulation, in order to deliver these skills and this knowledge. We then need to assess it robustly and thoroughly. And then in the longer term, we need to evaluate not only the practitioners whom we've trained, but also the curriculum that we're putting in place to make sure that they and it remain fit for purpose and capable of doing what we want them to do. And again, it's not just a question of devising a curriculum, making it evidence-based and implementing it. We need to be sure that we continue to evaluate and iterate our curriculum, because things change, circumstances change, case mix changes, technology changes, both the technology with which these the people working in remote environments will be working, but also the technology available to the remote healthcare practitioners that will, we hope, continue to evolve. And therefore, having implemented the curriculum, we need to continue to follow what's called the curricular cycle, defined by Peyton and Peyton more than 20 years ago, assessing the emerging needs, designing and implementing the changes to the curriculum, and then assessing the output of that change, and to continue to follow the curricular cycle. So this isn't just a one-off piece of work. This is going to be a long-term iterative process, implementing a curriculum, evaluating it and adjusting it iteratively as needs change. So how are we going to approach this in practical terms? Well, in the first instance, we propose a series of concurrent PhD projects undertaken by clinicians with an interest in education and in remote healthcare. This will be a series of projects that will be supervised by medical universities, certainly my own university, the University of Glasgow, and hopefully other universities will come on board and be able to offer supervision. We will obviously from the start be engaging with the relevant appropriate authorities. So in the UK, the Royal College of Physicians and Surgeons of Glasgow, for example, will be approached, and other royal colleges, and also the regulatory agencies, both in the UK and elsewhere in the rest of the world where we're intending to implement the curriculum. So this will be a lot of work. We'll be talking to lots of different stakeholders and external agencies as we develop this. And we will need obviously to contextualize the work of each PhD project to a particular region, because as I've mentioned, the spectrum of problems encountered by individuals working in Siberia, for example, will be quite different from those working in the Gulf of Mexico. So we will need to look at different regions of the world separately, and we envisage that these will be the focus of different PhD projects. So each PhD will evaluate the frequency of instant medical issues, problems, emergencies, and also the consequences of these. We'll be focusing each PhD on one region or one environment, and we'll also be building into the evaluation the availability of additional adjunctive resources that could be used by healthcare practitioners, such as availability of telemedicine and proximity to centres of medical treatment. And the intention is to define, in the first instance, the learning outcomes of a program that's going to be entirely evidence-based, in contrast to that which has gone before, totally fit for purpose, and also endorsed by the relevant agencies in the UK, in Europe, and across the world. So that concludes all I have to say about this. I've had a short period of time, and I hope I've conveyed the message clearly. There is an unmet need for a defined medical curriculum to improve the provision of healthcare across the world in remote areas. The IRHA is working towards the development and delivery of such a curriculum, although we're at the very early stages just now. It's a pleasure to be able to share this idea with an audience such as this, and we're obviously in listening mode and very keen to hear any comments or suggestions that you may have. And if any suggestions arise, my email address at the University of Glasgow is shown there. So that concludes all I have to say. All that remains is to thank you all very much indeed for your attention. And I hope at some more propitious time, when the pandemic has faded away, I'll be able to meet you all in person. So thank you once again for your attention.
Благодарим Мэтью Уолтерса за доклад. Поскольку
Thank you, Mr. Walters, for your report. But since it was already a pre-recorded report, then we don't have online connection with Matthew, then you can leave your questions either in the chat or per email. Okay, so the next
report will be devoted to remote healthcare curriculum. The report will be made by Malcolm Valentine from Great Britain.
I have entitled this presentation with a suitable saying as featured in the title slide. Knowledge increases by sharing, but not by saving, and never has this comment been more pertinent. Slide 2, please. I can bring the subject even closer to many attendees' hearts with my second quote, this time by a Russian. A man can only attain knowledge with the help of those who possess it. This must be understood from the very beginning. One must learn from him who knows. There you go. So this presentation is all about the sharing of knowledge across the broadest spectrum of international remote healthcare. There remains a very great gap in both the willingness to share knowledge and the vehicles for doing so. Only through sharing knowledge will it be possible to establish the core role and activity of the remote healthcare practitioner, and in turn for both the curriculum and the content of training to be properly defined. This is a dynamic process. It will never be complete. Additionally, there then needs to be a vehicle that can contribute to continuing professional development, so that practitioners can continue to learn and develop by sharing experiences freely and thus advancing the overall reservoir of knowledge and skill. Historically, one of the most important cross-industry and trans-company studies to try and audit remote medical activity was carried out in Aberdeen in the mid-1980s. A brief resume paper of this work was published in 1988, and I refer to that paper, Medical Evacuations from Offshore Structures. This study uniquely accessed the historical medical records of 4 offshore companies working on the UK continental shelf. It comprised all sectors of the shelf, the North Sea sector, South North Sea sector, and even Morecambe Bay to the west. It covered both oil and gas exploration and production companies. 2,162 evacuations for clinical reasons from 1976 to 1984 were studied, including 137, 7.7%, where unscheduled helicopter evacuation was needed. Slide 3, please. Amongst other findings, it was noted in the earlier years, more injuries than illness were noted as reasons for evacuation, but by 1980, this had equalized. Hand and eye injuries comprised 25% of all evacuations, possibly predictably. Dental problems, interestingly, comprised 5% of all evacuations. That's 1 in 20. The mean age for injuries was less at 28.3 years than the mean age of illness, which was 34.4 years. Even at the time of the study, focused training was just starting for the then termed offshore medic, as in theory only a first aid certificate was truly required to work as a medic. It was also true that many medics were ex-forces and highly trained and skilled in trauma management, less so coping with medical issues, which clearly were becoming more prevalent in the workload even by then. Early effects of the study included properly embedding bespoke training programs for medics at the Centre for Offshore Health in Aberdeen, and for those training programs to become progressively more focused on the acquisition of medical knowledge and skill. Also, for many years, UKOOA, that's the Oil and Gas UK Medical Advisory Committee, insisted dental certification be provided in medically assessing workers for offshore. This eventually wiped out the need to evacuate for dental problems. Progress continued on the evolution of medic training programs. But what has been done since? This study is 40 years old. Has any similar work been done, or is any similar work being proposed? What about continuous data gathering? There is no doubt that within individual companies involved in remote activities, there is now extensive data gathering, audit, critical review and feedback to individual healthcare practitioners. There may even be instances now of specific retraining in identified knowledge or skill gap areas. But what are the prospects for cross-cutting understanding? How much of the internal audit and measuring is shared out with the organisation? How much internal audit and knowledge is then available for external training providers to inform the design of their programmes, and how much of this information is made available for external study and research and peer review? Over the years, bodies such as the International Remote Healthcare Association and other professional groups have attempted to keep the issue at the forefront of remote healthcare thinking, and informally have sought to share information through conferences and the IRHCA journal. But this activity still remains at a relatively low level, considering the extent of the level of international remote healthcare activity now. Slide 4, please. The recent publication, Remote Medicine, a textbook, edited by Professor Norman and myself, attempts to provide a supportive textbook for the remote healthcare practitioner, but also seeks to establish, especially within the general medical practice section, a basic knowledge and skills inventory for remote practice. But these elements still need to be tested for validity, given that much of the information was sourced parallel to remote healthcare activity rather than being derived from it. So such a textbook would have even greater impact if it was possible to tie it even more closely to what was actually being experienced in remote healthcare. Further, especially in the energy industry, there is a need to more closely examine the specific attributes a medic might need to address in the future of clinical care for those working, for instance, within the wind power industries, the wave power industries, and even in future nuclear industries, including nuclear fusion. Much work remains to be done. And what about continuing professional development? CPD can cover a huge breadth of activity. It is a fundamental principle of adult learning that the content and methods should be meaningful to the individual. By means of examples of CPD activity, I have suggested personal study in the creation of personal learning records, reflection on situations that occur in normal work, for instance, significant events, memorable events, or unusual events, reflection on patient unmet needs and how to respond to them, clinical and system audit, writing up, learning and publishing, and also personal development portfolios. And I will forever reinforce the point about preparedness to write up and publish material, preferably in an accessible journal that can be shared widely among the breadth of the remote healthcare community. After many years of involvement, I have no absolute solution to offer. But for all those many years, I have identified that the sharing of knowledge is paramount. So the question remains, what are you, the participant, prepared to do to enhance this sharing of knowledge? Slide 5, please. Thank you for your attention.
Thank you for your interesting report. This is a question to the audience that was mentioned at the end of the report. So we shall move further in our agenda. We have 2 reports. And right now it's my pleasure to present the next speaker.
It's Dr. Harry Horsley, who is the medical advisor for the BP. And the topic of his report is the role, scope, and practice of perceived educational needs of offshore medics in the UK continental shelf. Please go ahead, Mr. Horsley.
Everyone, Chair, panel delegates, both in Tomsk and in the throughout the world. Thank you for inviting me to the conference. First of all, my background is not as a doctor, but as an occupational health nurse. And I've been involved in remote healthcare for quite some time now, since being recruited by Professor Norman to work with the Antarctic Survey very early on, and then subsequently been a university lecturer for 10 years. But I've also worked for 2 periods in the North Sea as a medic. So, and that's going to be the theme of my talk now. My presentation is based on a master's project which I undertook some years ago, which asked a large number of remote practitioners working in the United Kingdom, continental shelf, about what their role actually was, about their actual exposure to medical events and patient consultations, and also how they viewed the adequacy of the training they received, and crucially, what they perceived their needs to be. Can you see my screen all right?
Well, we don't actually.
Press green button, share screen,
Yeah.
and then blue button, sharing.
Yeah.
Yes, now we see your screen and slideshow, please.
Thank you. Yes.
Thank you.
So just to give you the international delegates some context on the United Kingdom continental shelf. Basically, when I talk about the continental shelf, it's the entire sea around the UK, but most of the oil and gas comes from the North Sea. The southern sector here is mainly gas production as well as the Irish Sea, but in the central and North Sea, it's mainly oil and gas. And it's a very important industry in the UK. It employs about 30,000 people, full-time equivalents, in the actual North Sea, but many thousands more onshore. The background is that the reason there is a North Sea industry goes back to 1967 and 73, when the Arab-Israeli wars produced an increase in the price of oil, and that politically and financially justified drilling in the North Sea, where extraction costs are very high. And these are some of the landmarks. 1965 was the discovery of first gas. 10 years later, first oil produced. And then in 1981, oil production exceeded consumption. But now it's declining, and we have to import about roughly half our oil and gas from abroad. The background to healthcare in the North Sea is that the National Health Service has no authority there, and it is the Health and Safety Executive, the HSE, that is the responsible government agency for healthcare in the North Sea. And the law, the legislation which governs it, was introduced in 1989, and this is it, the Offshore Installation Pipeline Works Regulations. It sets out that anyone working as a medic, and this is what we call remote practitioners, they must have either a nursing, military, or similar suitable background. So that includes operating department assistants, paramedics, etc. So it's a very mixed background. To work offshore, to get a license, you need 4 weeks initial training, and that includes 1 week with a general practitioner and 1 week in accident emergency. And then every 3 years, they must undertake 2 weeks of refresher training. Since the development of the offshore industry, there's been huge advances in safety, and this graph, these statistics demonstrate the reduction in the number of injuries. A very busy graph, but just look at the red line. This is the rate of injury per 100,000 full-time equivalent workers. And over the 15 years that this graph demonstrates, the incidence has actually roughly halved. And this trend was picked up, as my colleague Malcolm Valentine was indicating. This trend was picked up at a very early stage by Professor Norman and colleagues who in the early 90s looked at the reasons for evacuation, medical evacuation from offshore installations, and saw this trend of injury declining and illness increasing emerge, and that trend has continued ever since then. So injury now accounts for a very low proportion of the reasons for medical encounters offshore. The survey that I undertook several years ago now was based on a master's project, and there were 4 objectives to it. One was to establish a map of offshore medics in the United Kingdom continental shelf, and the reason I had to do that I'll come to later on. The second was to look at the demographic data, for instance, what age they were, whether they were male, female, how many years they'd worked offshore, their background, whether they were military or nursing. And then the scope of practice, what they actually did. And that were things such as how much trauma or serious medical events they saw, what other health-related activities they undertook offshore, the frequency with which they undertook certain interventions, particularly the advanced life support interventions such as CPR, defibrillation, airway management. And also another aspect which requires frequent practice, examination, i.e. listening to chests, testing reflexes, examining eyes. And the 4th objective was their perceived educational needs. So asking them exactly what they felt their education needs were, such as the perceived adequacy of the initial and refresher courses, the content of them, how well they prepared them for working offshore, the perceived adequacy of the interval, the 3-yearly interval between refresher courses, and any suggestions as to continuing professional development. I undertook the collection of data by postal questionnaire for a variety of reasons, rather than online. And I aimed to include all the medics who were working offshore at the time. But I soon discovered that there was no central health and safety executive register or database. And the information I needed really was held by medic training providers and employment agencies, but they wouldn't release that because of commercial sensitivity. So I ended up actually approaching individual operating companies and constructing my own database. The response rate was relatively good, 44%, and I got 101 questionnaires returned. Of those, 84 were males and 17 females, and the median age was 45 years old. And the median number of years of offshore experience was 10. Significantly, female medics who were significantly younger and had fewer years of offshore experience than males, and that reflects the very low number of females offshore and the fact that they don't find, I think, that environment very welcoming. In terms of qualifications, 32% of the respondents had a military medical background and 68 had a nursing qualification. Over 60% of them had secondary roles other than medical, and that included administrative or safety management. The number of patient encounters in the case of serious ill health or injury were very, very low, and the frequency with which they had to perform emergency procedures such as advanced life support was again very low. And most respondents estimated that injury accounted for fewer than 10% of consultations. And in the 4 weeks prior to the questionnaire, I asked, how many patient encounters have you had? And the results were quite surprising. So over half reported fewer than 12 patient encounters per week, and only 30% reported 10 to 25 patient encounters per week. So all of this points to a very low medical workload and the issue of skill decay, and that's where training comes in. So in terms of the adequacy of training, most respondents said that they felt that the initial and refresher training content was adequate, but it very much depended on their own backgrounds. So if they'd worked in accident emergency, they were comfortable with trying that. But a nurse who had worked with the care of the elderly, for instance, that would be a very, very steep learning curve. There was some indication of differences in standards between training providers, and that's a well-known phenomenon amongst the population. And skill decay was a major issue. 55 out of 78 respondents wanted more frequent, shorter duration updates rather than 2 weeks every 3 years. When I asked about the quality of support from doctors onshore when they had a problem, the majority expressed satisfaction with the service that they used. There were some comments, however, as to some variability, some variations that support, i.e. delays in speaking with a doctor, and quite worryingly, some doctors' unfamiliarity with the offshore environment. So all of those previous results have been quantitative questions. I did leave space for general comments, and several themes were discernible when I undertook qualitative analysis. One was their perceived low status in the offshore industry, a desire for increased professional recognition and interaction, some less administration or other non-medical duties as secondary roles, and an issue about the majority of medics working as contractors or through an agency rather than as a staff position, and the power position that put them in with management. So the big issue for me was that there is no register, and there still isn't, of health and safety executive accredited medics. Skill decay is a very big issue, and the frequency of refresher training and CPD needs. Professional isolation, ensuring that they receive appropriate medical support, and monitoring the quality control of training course providers. So registration really, I think, is a public protection issue, because if there is no means of withdrawing the HSE license and debarring them from practice, then that really is a very big public protection issue. And with registration, that would allow professional recognition and development. And without registration, there can be no real effective regulation of these practitioners who work offshore. So thank you very much. If there's any questions, then I can take them later on.
Благодарю за доклад.
Thank you for your report. We are waiting for the questions from our colleagues. Yes, we do have a question. We do have a question. Thank you so much, Professor Horsley. We do have one question about the preparation. Is there special training in the UK for the sailors in the UK vessels, for the vessels in the UK? So special training for the maritime medicine.
My specialist area, but I believe that what we would call seafarers, sailors, I think they all have to undergo basic first aid training, and then senior officers undergo a training course, which is called the Masters Medical Training. So anyone who has a license as a first officer or a captain has to have that training. And I believe that's a 5-day training course. And generally speaking, on British vessels, it is the first officer who has responsibility for the medical management.
Спасибо за доклад.
Thank you for your report and for answering the question. Are there any more questions? No more questions offline. Since I do not hear any questions, we do have one more report, and we will dive into 14 minutes in our break. And David Page is about to present. David Page from the USA, from the IMT associations, the paramedics associations.
Пожалуйста.
Hello, greetings from the United States. My name is David Page, and I am the director of the Pre-Hospital Care Research Forum at UCLA. I'm an affiliate faculty member for the National Association of EMTs and do a lot of work internationally for NAEMT. I also teach in the paramedic program at the Center for Pre-Hospital Care at UCLA, part of the David Geffen School of Medicine, and currently a paramedic at Allina Health and adjunct faculty member, senior lecturer at Monash University in Australia. It is an honor to be with you, even if it's remotely, to discuss really a wonderful association that I've been a part of since 1987. I've actually been teaching NAEMT courses since that time. I took the pre-hospital trauma life support course in 1987 and just fell in love with it. Our organization has 72,000 members and growing. It was formed in 1975. And we're proud to have amongst our ranks practitioners of pre-hospital care of all sorts of training. So paramedics, EMTs, physicians, nurses, anyone really involved in out-of-hospital care or paramedicine, as some are calling it now. NAEMT focuses on education and advocacy, research. We really want to advance our profession based on evidence. And our mission is to improve the quality of care. Really, that's both by supporting our members that are professionals and also by providing quality education that is essential to delivering the best care possible based on the latest standards. We are led by a board of directors. This is an elected board, and there are 18 staff members. We have 14 different committees and volunteer coordinators. I'm a member of the education committee, as an example. We participate in all sorts of advocacy for education and also for changes in legislation here in the United States. We are partners with a great variety of organizations that also represent physicians, firefighters, fire chiefs, emergency managers, government entities, as well as ambulance associations and healthcare officials. We also spend a bit of time in Washington, D.C., along with our colleagues trying to improve the laws that help protect our profession and help patients, as well as finding funding and preparedness for disasters, pandemics like the one we've been living in this past year. Our education is really what I'm here to talk to you about mostly. It is comprised of 12 different courses. They're really wonderful, and I wish I could spend all my time just talking about each one, and I would never stop. We have a catalog that actually describes these in great detail, but and it's available online at naemt.org. But I really want to tell you what they mean to me. And some of these courses, I think, are really a part of how we do our work in the U.S. I, for example, have worked for ambulance services that required PHTLS before you started to work. It's a bit like BLS or CPR certification, where everyone knows, and ACLS, where everybody knows how to interact with each other. We know what the latest techniques are for teamwork and crew resource management, for culture of safety. We advance with the latest techniques. When tourniquets, we found out, were better than just putting direct pressure, we immediately put those into the course. And the courses are highly specialized in some cases, and also a mixture of both active learning, such as participation in group discussion or cases, and a lot of simulation. We really think that hands-on learning and being able to interact with instructors and think critically is the most important. So we use the latest education techniques, which I'm very proud of in our education committee, to infuse those in all of the courses that we do. We also encourage people to practice safely. You see everybody here in personal protection, outside, in the environments that we're actually going to be working with the tools and the equipment that we're actually going to be working with. PHTLS is our longest standing course. We've had this, like I said, I took it in 1987 and started teaching it thereafter. It's a minimum of 16 hours, but you can teach it in many more hours. As an example, in some of the universities and paramedic programs here, it's taught throughout the entire semester, and the textbook is used as the trauma course textbook, at the end of which we actually give the final exam and certification. There are hundreds of simulations that are wonderful, but we always say a minimum of 16 hours is what's needed, especially if it's continuing education. We simulate the patient in whatever environment, including the ambulance. So this is not just a class that you would take and sit in a classroom for. We want to get students out of their seats. We have opportunities to do scenarios to start with, and then concentrate on what techniques we can improve upon if people are taking it, for example, as a continuing education course. All of our courses can be tailored to the specific protocols for the area that we're in. I've taught them, as in the case for advanced medical life support, which is more critical thinking, kind of a detective course of differential diagnosis. And we've taught this in Malaysia, in Kuala Lumpur. We had a wonderful course, as well as in the Philippines and in Mexico and Colombia. These are amazing courses that where teams of people, even if they're different levels of training, can collaborate to care for a patient and learn about very important complaints and how to create differential diagnoses. Of course, pediatrics is so important, and we have a robust program for pediatric care, as well as, this is in partnership with the American Academy of Pediatricians. And this course, I think, is wonderful because so many people are so uncomfortable with children, and it's very needed. One of our newer courses is the All Hazards course. This is a course that's dedicated to organizing a disaster or a group of people who are going to respond to the disaster, learning to plan for what the community might need. In Mexico, that might be an earthquake. In the Philippines, it might be a monsoon, or we think about what that community needs, and then we actually do a simulated disaster if we plan ahead and have time for it. So again, just a wonderful course on the how to manage disasters and all types of hazards. Another wonderful course, psychological trauma in EMS patients, a bit of psychological first aid, how to deal with the emotional components. And I love the geriatric course, for example. We have, this is a course where we have our students actually walk around with rocks in their shoes, and we put tape on their fingers to really simulate what it feels like to get old, like me. I've been doing this for 35 years, and so I can tell you that the bones, the ambulance crashes, it feels like it's, been a while. So having these young students actually experience what it's like to lose a bit of your sight with eyeglasses that have some fog in them, and not have the mobility, really teaches them to live and empathize with people who are older patients. So the GEMS, or Geriatric EMS course, is just a phenomenal course. And of course, our safety is incredible. The ethics and leadership is badly needed, I think, in our profession. Fascinating to talk about ethics. We have courses that are specifically for law enforcement responders and firefighters or military, like the TCCC course as the tactical combat course. We hope we don't need those things, but here, for example, we had a lot of civil unrest and had to learn to work in very dangerous environments. So these are really amazing. The First on Scene course is dedicated just for the initial person who arrives at the scene. And there is an extensive community paramedic, also mobile integrated health is a name we use for that. And the vehicle operator course, that I can't express I wish I could show you some of the videos. These are not, this is not learning to drive fast, but it's learning to drive safely. It's really just a wonderful combination of different disciplines and courses that give us a great enrichment and technique and competencies, all of them evidence-based, all of them updated. We have specific committees that update these guidelines based on international standards and go out of our way to look for the latest evidence, evaluate it, and put it into practice in these courses, as well as looking at consensus statements and finding just exactly what is the best way forward to teach this. So latest teaching techniques, latest information in the courses, along with materials that are really well put together. Our national and international training centers are intended to, so if you're wanting to teach this, you would become an NAEMT training center. And we launch the course usually as a provider course, and then the instructors can take it as a student, and then they teach the class and we help them. So as an affiliate faculty member, I observe and assist and learn from them actually most of the time about how wonderful they do with their courses. And that's how the NAEMT training centers begin to teach their own courses. And these certifications really blossom. People are very proud to have them and proud to have the knowledge and get the knowledge updated. It's been, these courses have been translated in many different languages, and it's really wonderful to see them continue to grow. So there's usually a coordinator of the training center, and it doesn't cost anything to become a training center. And in fact, many of the training centers actually provide courses for a fee. So in some cases that is done at very low cost. In some cases it's done in a super amazing way for people who can afford it, with costs then paid for by the students. But we are a nonprofit organization, and we really want to get our education to be available to the most number of pre-hospital providers that we can. I again want to just thank our partners. The American College of Surgeons has been an amazing partner with the PHT, or Pre-Hospital Trauma Committee. And I can't do a presentation about NAEMT without talking about our great Norm McSwain. Dr. McSwain has contributed so much to PHTLS in particular, and helped us launch this platform of wonderful courses that are available to you to teach in your country. The American Academy of Pediatrics, again, having the NAEMSP, the National Association of EMS Physicians, the National Registry. These are all organizations that help us here and are partners with us in these courses to make them that much better and have their stamp of approval. It was wonderful to join you. I hope you have questions that we can answer. Please contact NAMT directly at namt.org. And I'm just thrilled that you're doing this conference. We very much need to work together across the world to improve pre-hospital care. Thank you, and I hope this was very helpful.
Благодарим за доклад.
Thank you for your report. We increased the time of our session, but the report was very interesting, and it is a pleasure and an honor for us to have a specialist from the United States, because this country offers wide opportunities for a variety of aspects. I would like to remind you that you can write your questions in the chat, and then we will give these questions to the speakers. So to sum up, I would like to say that the discussion was quite fruitful, international. We discussed evidence-based medicine, training of medics in remote sites. I'm thankful to all the speakers, the audience, and as I suggest we have a short break and then continue according to our agenda. Thank you. Hello, dear colleagues, ladies and gentlemen. I'm glad to welcome you at the session devoted to maritime medicine. I was asked about 10 minutes ago how maritime medicine appeared in the agenda of the conference. We met with Mr. Lgunov time ago, and we realized that marine medicine and remote medicine shall go hand in hand with each other, and we meet almost at every conference. Our first speaker is Yuri Zakharevsky, professor, head of training in the specialty general medicine, Murmansk Arctic State University, corresponding member of the Russian Academy of Natural Sciences, neurosurgeon of the highest category, colonel. He's a well-known military doctor. Please, you have the floor, Yuri. Hello, we're happy to see you. Do you hear us well? Now you can take the floor. There are some technical problems and they need to put on the slides on the screen. You can begin, and then we will try to fix the problem with the video. I will begin the report then, and we will see how it goes. Dear colleagues, the volume and nature of medical care in the Russian Navy in the sea, as in any countries of the world, is always determined by specific historical conditions, development of medical science, and medical equipment and technologies, achievements of naval surface and subsurface ships, creation of direct conditions for medical healthcare in the sea. As the technologies medical technologies are improving, and the medical equipment and tools are developed, we have more opportunities for providing decent and efficient medical care, especially at naval surface ships and submarines. From the point of view of the history, the first submarines in 1909, they were rendering as medical assistance to each other, the seafarers. But then in the Soviet Union, there was a paramedic position introduced with the necessary medical toolkit. Then German and Russian ships during the First World War had experienced the need to engage medical personnel, be present at submarines to provide the necessary medical care. Then in the 20s and 40s, due to the great number of submarines, there was an urgent need to have a paramedic on board. And this happened until the end of the Second World War. For the first time, the issue of surgical care in sea appeared for the first time in 1942 with an increase of the duration of the submarine routes and voyage in the sea. In many cases, they diagnosed the acute appendicitis in the Atlantic, in the sea. So there were many cases with appendicitis. And until 1946, the surgeries were not performed on submarines. Due to the development of the naval navy, on the Russian Navy, they built 337 submarines, nuclear submarines, and other types of submarines. The scope of medical care increased a lot. The first surgery was done in Russia was by a doctor from Petropavlovsk Hospital underwater. In the future, after 1957, such operations were performed in all submarines, and their number was increasing. In 1957, in the Soviet Union, they introduced a position of a surgeon in all submarines in the oceans of the Soviet Union. And starting 1956 up to 1900s, there was a golden age of the Soviet Navy surgery. There was a department and an institute that trained surgeons for naval industry, that were able to make these surgical operations both on ships and in submarines. And since then, hundreds of surgical operations were performed. The construction of nuclear submarines and their submerging under ice also created the need for surgical operations. And 165 operations were performed, including the most serious ones. Despite the lack, since Russia and the Soviet Union didn't have hospitals along the seashore of the world ocean, the Soviet Union decided to build the supply base that would provide the necessary facilities and equipment and personnel to these seafarers. So about 30 of such units were built at that time. Besides all the necessary food that was available for seafarers, they provided the necessary medical care. There was a surgeon, pediatrician, therapist, and a resuscitator. So all the operations were also conducted, not in the submarine, but, for example, in these specially designed medical centers. Down those floating bases, as they call them, were improved, and the amount of necessary medical equipment was also enhanced. And here on this slide you see some examples of the big ships that were designed especially to provide the medical assistance to people serving on board. There was an active construction of specialized military ships. These are the floating hospitals. One of them you see here on this slide. One of them is actively used in the United States. They are used in military actions in Iraq, for example. Scientific journals publish a lot of articles about the advantages of such ships. There were 4 hospital ships for medical support of marine workers. And you see also them on this slide. They are called Yenisei, Svir, Irtysh, Ob. They contain a resuscitation room, resort room, the room of neurologists and many other specialists. Up to 450 beds for the patients. Such ships are also widely used in emergency situations, in rescue events. Sometimes such ships are also used to provide humanitarian aid to the countries suffering from some disasters, for example. You see what is the quality of these beds and the wards inside those ships. They seem to be rather good. This made it possible to provide medical assistance to seafarers on board and to evacuate the injured people from the ship. Like on the 25th of March from Virginia ship, they were able to evacuate a seafarer, and in April from Georgia ship, they also transported an injured person to the hospital, which is very important in our days. Active surgical activity in the sea with the surgical teams. In submarines, there are 2 surgeons normally, and they have all the necessary knowledge and skills to provide medical assistance and do the operation under sea. Besides, the problem of traumas is quite relevant. The problem with emergencies, accidents. Then the John McCain ship, in case of emergency, on the 25th of August 2017, 10 people died and 5 were injured. There was a need for evacuation, And on the 11th of June, the Fitzgerald ship also collided with another ship, and several people were injured. So the necessary medical assistance was provided on time. Important events on the prevention include medical checkups, pre-route examination. According to the order of the Ministry of Defense of the Russian Federation, 100% medical expertise is required for all the employees of the ship or a submarine in order to detect any hidden pathologies and to prevent any diseases or illnesses in the sea, so that such unexpected situations do not occur. There are protocols and certificates based on those examinations. For example, to prepare the crews of large ships, can you go to the previous slide? There is a need for deep examination. For example, it may be 2,000 seafarers or 1,000 seafarers. So this requires a detailed examination. We can say that this approach of pre-route examination was justified, and we were able to prevent and early detect the diseases the seafarers might have before going on a long route. Due to modern requirements to medical care in sea conditions, the Russian Federation tried to reinforce the qualification and number of doctors serving on ships. For example, starting in 2015 to 2018 or 2020, in this North Fleet, there were 26 reinforcement groups, as we call them. And you see in 2016 it was 21 group, 2017 32, 2018 28 groups, 38 of which were workers. In order to provide medical assistance, they attracted the specialists from Maritime Academy, which made the quality of training of marine staff stronger and improved the quality a lot. Now the naval medicine includes different specialties like surgeons, neurosurgeons, resuscitologists, dentists, and so on. This slide shows you the medical brigades recommended for large surface ships when performing their voyage in Syria to fight with terrorism. An important achievement of the Russian naval medicine was the highest level of specialized medical care, namely the introduction of laparoscopy, presence of mobile laparoscopic equipment, SKT SKT-1 produced in Russia, manufactured in Russia. And some Russian ships already have this SKT-1 laparoscopy complex installed on ships, which makes it possible to do the surgeries at a different level. So this is an example of a surgery in sea under urgent conditions. Here we see the statistics of the rate of traumatism. The general illness level, incidence level was also reduced. So the number of people with good health is increasing year by year. Our teams provide medical assistance when getting from south to north seas, and due to these climatic changes, different problems with health arise, like pneumonia, lungs of different severity. Dentist help is provided in specially equipped rooms that are available on large ships. There are some mobile equipment, dental equipment also that can be placed on smaller ships. So these are the examples of tools for functional diagnostics, ECG, fluorography, and many other treatment methods. So every single ship is equipped with these devices that are able to perform various types of researches and examine the health of seafarers. One of the tasks for the Russian Navy is the introduction of the first and second rank ships, the telemedicine complexes that are well recommended and that are highly efficient. That are using the telemedicine equipment. They transmit the necessary data, decode this data, provide the report to the in-ground or inland facilities. Up to 2024-25, we plan to equip all those large ships with telemetry equipment in Russia. An important task of the Russian Navy is to fight with infections and prevent those infections, especially in hot areas. This concerns the yellow fever when they travel around the African continent. So vaccination against this yellow fever is obligatory before seafarers get on ship. In case of other injuries, there are some training sessions arranged how to provide the first aid treatment, how to save the injured from the sea surface, and other medical care. In the Karachi port in Pakistan, we conducted a joint training with our colleagues how to render medical assistance in case of gun injury, an important component is to prepare the ships and the medical rooms for long voyages. Then for this purpose, the Russian Navy has a special algorithm and procedure for training, equipment supply, oxygen supply, other medical tools. All services of the ship are checked, including the medical service, before the ship begins its voyage. This inspection is on the readiness of the ship, on the necessary equipment, the necessary medical drugs, equipment, devices, oxygen. They check also the knowledge of medical workers in terms of different pathologies that may occur in the sea. Yuri, you have to sum up because we are running out of time. In order to save life, this is done in order to save life of the seafarers in any place of the world. Thank you for your wonderful report. If there are some questions, can you introduce yourself first? Hello, Yuri. My name is Denis Starostin, resuscitologist. Thank you for your report. It's a pleasure to know that the Russian naval medicine is doing well. Can you tell us how do you account and store drug precursors in sea ships? Thank you for your report, but regarding the drug preparation, this problem is stored and this problem of drug preparation is solved according to the regulations of the Russian government, and they are kept in a special box and are only used for special purposes. So we handle them as prescribed by the law, in other words, or by the order. They are only used in emergency or in military events. So this problem is no longer a concern of us. Thank you. Thank you for your interesting question. Now we have another question. Can we use the competences of the Ministry of Defense and use this order for civilian ships? Because this will make our life easier, but this is another discussion. So we shall turn to the next speaker.
It's a dear colleague of mine, Luisa Polina Canals from Spain. Luisa here is a specialist in occupational health and hygiene, and she was the founder of the postgraduate courses for maritime medicine in the University of Tarragona. They started first in Tarragona, and then they were transferred to the Cadiz University in Spain. It's about training fishermen and seafarers for the medicine on board. Just a remark that in Spain, fishermen and seafarers are one single group. They are not divided into two groups, and they receive common training. So, Luisa, you get the floor. Please go ahead.
This good morning in Spain, but finally we managed to connect with you, and it is a pleasure for me to be invited to these interesting meetings. I was already in the one in July, and so it is a pleasure to be with you again. So the subject I will talk about is a little bit different. I will share my screen. Okay, I hope you can see it. The title this time is talking about tools and training related to the fishermen and seafarers for telemedicine on board. What does it? This means that mainly the knowledge that they have been learning in the courses, the first aids and medical care courses, will be applied for the radiomedical advice consultations. So they will be the eyes, and they will be touching, exploring the patient. They will be the ones that are commenting what is happening on board with the injured person or the seafarer that has a disease. So this is very important to have this health responsible on board. And I want to explain to you how we are managing in Spain in my maritime health program. That is a program that belongs to the government, to the ministry. And it is for all Spain. And as far as I was explaining to you last time, it's complete. The maritime health doctors in Spain are doing training, seafarers and fishermen, and doing the medical examinations, are doing radiomedical advice consultations, are in hospital ships, are also participating in the repatriation of the seafarers and fishermen that are working on board, especially in Africa. So this is a complete program for us. And we also are doing the inspections on board. The Maritime Labour Convention 2006, for example, and others. So, well, here, this is what we are pretending with these courses, that is the prevention. So we give them some tools like the first aid kit in the small ships and a big medical chest in the big ones. We are following the STCW convention, IMO, and we have ratified the European directives related to the training also, and related to the medical chest, and related to a lot of rules and regulations that are transferred in the Spanish rules and regulations program. We have mainly these three types of courses: a basic for all the seafarers, initial for the responsible of the first aid C, because in Europe we have three types of medical chest. The smaller one is the C, and the biggest one, that are three, it is complete, we will see some pictures, is A. A and B are very big, and C is a small one, a first aid kit. So these three courses, the basic, the initial, and the advanced, are addressed to different positions on board different types of ships. And also we have every 5 years a refresher course. So the two that are related to the responsible person on board of the health are the initial and the advanced. The basic is for all seafarers and fishermen, it is compulsory. So this would be the basic, compulsory for all seafarers. Why? Because in case of accident, everybody has to be prepared to assist this person, to reduce risk and to take an immediate action to avoid fatal sequelae. These are very different types of accidents on board, but many of them implies also an injured person. we are doing a lot of campaigns, health promotion for preventing the accidents, and teaching what are the risks in each part of the ship. We have also some manuals or books that they have to follow, and they have all this training also online. For example, the specific initial medical care training course, and the objective is to give them competences in first aid, elementary nursing techniques, and radiomedical consultation procedure training. This is the main important part. The telemedicine that they are using on board when they are injured or when they have a disease. So it is addressed to the creation of this responsible person of the health on board. It can be captain, a skipper, officers. So they, for those that have the first aid kit C, according to the EU, European Union directive, they have to have this course and a refresher every 5 years. For example, this is a fishing ship, maybe navigating less than 10 miles far from the coast, but they have these small first aid kits, they have a medical guide on board, and they are trained to solve any problem, and they also can have these radiomedical advice consultations. For these ones, we are, for those that are choose to be trained presentially, they have 24 hours teaching, 11 theoretical that can be online or can be presential, and 11 practical, never online, but practical. So they are able to contact with the radiomedical advice center, and also they have some tools to facilitate the consultation. For example, this is a drawing, a picture showing, for example, if they want to say the painful area, they can show with these letters and numbers to the doctor that is in the radiomedical advice center. Okay, so they get their diploma with the contents of the course. In the case that 5 years after this course, they need to be a refresher. The refresher is always practical. It has to be presential. And we have a we short the content of the course, but all is in practice. No online for this part, if it is a refresher. So they have to learn how to, for example, in the practical, how to take the blood pressure, or how to transport an injured person, or to make bandages. This is the advanced one. For the advanced course, then we have higher objectives, and it is addressed to captains, skippers, and officers that have to be in charge, the health responsible person for the medical chest A and B. So these persons are also controlling hygienic conditions on board, and they are the responsibles of the risk prevention programs. So if you look at the medical chest, this is bigger, this is the B. For ships that are going more than 60 miles far away from our coast. They have even oxygen and other devices. This is the distribution, the timetable, the subjects, and these ones receive 40 hours teaching. The theoretical content can be done presential or online, and it is about 18 hours. And the practical content, always presential, has to be at least 21 hours. This is the tools we are using for training to learn the anatomic, the body, to check the patient for the exploration on board, how to transport, even how to use for example, special nurturing techniques like endovenous punction for some special treatments. So these ones are well trained. And especially we insist on the resuscitation techniques. How do we evaluate these courses? Well, online, if they choose the online for the theoretical part, in this case, they pass some test, and when they are prepared, they have till 4 months to contact to center in the coast where we have our maritime health doctors and do the practical part. I say till 4 months because sometimes they are starting the online part and then they are navigating and they then do not have the possibility to go online for the presential classes. So we give this time, but the normal thing is that they do the online part, the theoretical part, and then immediately they can go, if they are on Earth, to this Maritime Health Center to do the practical part. And if they are doing all presential, they can only miss 10% of the classes. What we are doing for the evaluation, normally we are testing the knowledge, the aptitude, and the skills. So we have a multiple choice examination with normally 4 possible answers, 1 right, and they have to have 75% good to pass this exam. But we also evaluate the practical part. And for the online, there are also regulations in Spain how to do this. Not only the government can do these courses, but also some private schools that have to be homologated, and they are audited for the maritime health doctors. The diplomas are always given by our government. So we prepared these seafarers and fishermen for telemedicine, for the radiomedical advice consultation, and to be there as the responsible person on board, because they have no doctor on board, but they have these telemedical possibilities. So they have to transmit the information, they have to explore the patient, and they have to take the action recommended by the doctor. These are some statistics of pupils. If you see, for example, this year courses, now a higher number of seafarers and fishermen choose the online part for the theoretical part. Many of them are coming from the schools, of the nautical schools, and they are now used to these techniques too.
Luisa, you have 2 minutes, please.
Oh.
Yes, you have 2 minutes left.
And prevention. This is a link in our program. And these are spasiba, thanks. And these are the information that doctors have also to be trained in maritime medicine. That's all. Thank you.
Thank you so much, Luisa. Muchas gracias.
Thank you, Luisa. Do we have questions from the audience now? We do not have any questions in the chat, and we are now moving forward to our next speaker, who is
This is a young doctor from Thailand, Pangrup Charyen. The fleet in Thailand is also quite young. It was established in 1946. Marine medicine in Thailand is quite young. So they decided not to invent a wheel. They invited the best specialists from the whole world and together created one of the most ideal systems that exist at present, with 3-year training of marine doctors at the universities of Thailand. Can you hear us?
Hello. Kapun Kaka.
สวัสดีค่ะ
Sawadika.
I could not hear you, Ilona.
And now?
Okay, I'm listening to you.
Okay, please, the floor is yours. You can start your presentation.
Okay. ยิงถูกแล้วก็ Could you see my slide?
Yes.
Okay, thank you very much. Thank you for your invitation for this conference, and good afternoon, everyone. It's a pleasure to have you with us today. Let me briefly introduce myself. I'm Lieutenant Commander Pangram Yongchalerm. I'm a specialist in board of preventive medicines and in sub-board of maritime medicine, and currently working in naval medical department in Thailand. The topic I would like to talk about is the vaccination in Thailand seafarers. I've divided my presentation into 4 parts, and I will begin with introduction. Then I will move on to types of vaccination. The next is vaccine preventable disease, and after that, the conclusion. There will be time for questions after my presentation. First of all is an introduction part. Seafarers can be considered as a unique population with its own needs and constraints and requirements for international travel. And of course, to protect the health of seafarers, passengers, and the general public, and to minimize disruption of global supply chains, vaccination of seafarers is considered highly preferable. Because of seafarers have to worldwide travel, embark at any port in any country, so they have more risk of infectious disease significantly in different parts of the world. Therefore, pre- and post-traveling assessment, including after starting on board, assessments are necessary as well. We have to get the idea that what the pre-travel counseling concept is. It consists of background of travelers, risk of traveling, risk assessment, and risk management. The background of traveler you have to consider is what drugs seafarers have used until now, or what the disease at sea that seafarers could have, or what the vaccination seafarers have received before. And for the risk of traveling, you have to know about where the seafarer traveling through, or how long of period they have to stay that place, and what season or the target destination seafarer traveling to has the endemic disease or not. And the last one is risk management. If you know what risk is, you could manage the risk and control it before you going on board, such as giving them the vaccination to seafarer, or maybe have some recheck the lab if they have any health themselves problem. The next part I would like to talk briefly is types of vaccination. In general, there are 2 types of vaccination. One is live attenuated vaccine or LAV, and two is inactivated or Q vaccine. LAV has a strength part that it induces strong lifelong immunity more than Q vaccine, while Q vaccine has more stable and safer than the first group. LAV is, for example, typhoid vaccine, yellow vaccine, and varicella or zoster vaccine. And the Q vaccine is, for example, influenza, hepatitis A vaccine, or rabies. Let's now take a look at vaccine preventable disease. And since we have not much time, so I will emphasize only VPD. Vaccine preventable disease could divide into three groups. One is required vaccines that the seafarer or travelers must be vaccinated. Otherwise, they could be rejected to travel by authority of that country. Two is routine vaccines that they are expand program of immunization or EPI of each countries. All population in the country must be vaccinated. And the last one is recommended vaccine that the medical staff would consider of all pre-traveling concepts as I have talked before. About yellow vaccine is kinds of serious viral hemorrhagic fever and blood-borne transmission. Its vector-borne is spread by Aedes, and symptom is some kind like influenza-like illness with fever, headache, or maybe some have nausea and vomiting. Of course, nowadays, no specific curative treatment for yellow fever, but anyway, it can prevention by vaccination, especially in seafarers who have to travel in the endemic area. In this yellow fever maps by CDC show the epidemiology of yellow fever. And as you can see, the vaccination has been recommended in the country in Africa and South America that highlight with yellow color. Endemic in 42 countries in Africa is about 29 countries, and South America divided in 13 countries. And what about risk of yellow fever? The data here show that WHO estimates some 200,000 cases occur each year, which almost all of these are in sub-Saharan Africa. And the risk for seafarers will forget that seafarers are at risk in all areas where yellow fever is endemic, and the risk is greatest to visitors who enter the forest and jungle areas. WHO position vaccination strategy to endemic countries and travelers. And to sum up in this table, yellow fever vaccine should be offered to all unvaccinated seafarers who are traveling to and from this area unless the vaccination is contraindicated. In this slide content, I would like to show that the yellow vaccine is safe, affordable, and highly effective vaccine. Besides, its effectiveness is quite strong and lifelong immunity. And of course, it's widely used to protect seafarers or travelers of endemic regions of tropical South America and Africa. The right yellow picture is the figure of yellow vaccine logbook. It is a proof of yellow fever vaccine vaccination and being signed by authorized physician. Exactly that failure to secure validation can cause seafarer to be quarantined, denied entry, or possibly revaccinated at the point of entry to any country. For the hepatitis A, typhoid, cholera, and polio, I would like to focus about the risk for seafarers. In hepatitis A, the risk of infection is involved with non-immune seafarer that visiting to developed country especially who exposed to the poor hygiene of food or water condition and sanitation. So that the indication of hepatitis A vaccine, some textbook or journals suggest that the catering crew staff must be free of enteric disease. And for typhoid, in general, typhoid has low risk to seafarers, except in parts of North and West Africa and South Asia. Both continents is still in high risk, and the risk of infections is involved with low standard of hygiene and sanitation as well. The vaccination is recommended to all travelers or seafarers who go into this area. Besides, cholera and polio is recommended for seafarers that should be vaccinated when visiting area is with ongoing or expected that disease in epidemic area. And the last vaccine I would like to focus is COVID-19 vaccine. Many COVID-19 vaccines authorized for use in different countries that they are reported to be more than 50% efficient in preventive disease in those vaccinated. But in some cases, efficacy data is not yet public or peer reviewed. After the injection vaccine is given, the protection starts to develop approximately 12 days. And it said that it is currently unclear that the authority in different countries will accept all vaccine available today or in the near future to permit entry within their borders, and always recommend information about the vaccine obtained and hard or electronic copies to certify proof of vaccination. Somehow, they are currently recommendations that if the seafarer have to shot the vaccination, they are suggest that second dose of vaccine should be the same as the first dose. This data, I would like to show you some the data I have received from Thai Ship Owner Association or TSA. They state that about the problem they face now is one is current situation or problems. They state that stakeholders or government do not have clear or exact protocols or guidelines for all Thai seafarers, and they have registered by application, but most of them could not access to any vaccine, or maybe they could not receive second dose at the destination country, although they have the single dose in Thailand. And or maybe while on board, seafarer has been notified to get the vaccine at the vaccine center in Thailand, although they still may be on board at the sea. And what should they action now? They do now by try to contact or coordinated with other stakeholders or government to have the clear resolution. But some of them have the depart although did not receive the single dose vaccine. And of course, they try to contact the destination authority to receive the vaccine. And the last one is how they resolve suggestion from Thai Ship Owner Association. The stakeholder or Thai government should have the clear protocol for all seafarer vaccination of COVID-19. And they think that Johnson & Johnson or J&J vaccine is preferable because it's used only single dose. And somehow it still not be approved by Thai FDA. Or maybe they suggest that if the seafarer is still on quarantine center, for example, hospital, the seafarer should get the vaccine at this time for have not lose weight with time. But now Thailand have mainly vaccine about CoronaVax, AstraZeneca, Pfizer, or maybe have some Moderna. We think that it approximately come into Thailand before this December. But now in Thailand, combination vaccination that recommend is Sinovac plus AstraZeneca or AstraZeneca plus Pfizer. As a final point of conclusion, I would like to have a little take-home message that prevention and precaution before departure is important, and understand and realize the target destination of local disease or endemic areas is important as well. And I would like to emphasize again, to protect the health of seafarer passengers and the general public and to minimize disruption to trade of global supply chains. So the vaccination of seafarer is considered highly preferable. Okay, thank you for your attention. Or if you would like to ask or discuss with me about the presentation, you could contact me by this email I showed to you. And if you would like to follow and subscribe about academic activity of Maritime Medicine Resident Training Institute in Thailand, you could follow by this page Facebook in this slide I showed to you. Thank you very much again, Ilona. I return floor to you.
Thank you, Пан Грум. Большое спасибо. Если у нас...
Thank you very much. Do we have questions? We have one question. Dr. Pangrum, thank you very much for your interesting report. Can you tell us, you mentioned the training or preparation of seafarers in Thailand and their vaccination. As you know, in 2004, there was a horrible event in Thailand. It was a catastrophe, a tsunami. Can you tell me, when you developed these special training programs or the programs for the preparation of seafarers, did you took into account some mechanisms or approaches or scenarios to train them or to prepare them for such extreme situations? Thank you. Can you tell me, are there any special programs to train seafarers in case of catastrophes or emergency situations? Are there any training programs for seafarers in case of emergency? Yes.
About in your question, I understand, but I think that the data you asking me is have to I would have to check with the port authority in Thailand, because in the event of tsunami last 10 or more years, I'm not sure about the data, but I will have to check the data for you as soon as possible and answer to you immediately as I can. Thank you.
Thank you, dear Пан Грум. Я, наверное, хотела бы добавить, что...
I wanted to add, Pan Grum was talking about vaccination. Unfortunately, these days, right now in our countries, they forget about other types of vaccination, because the only vaccination important right now is the COVID-19 vaccination. So only those seafarers that work on cruise ships and on offshore platforms are vaccinated. For other workers, no one belong. And nothing shall be changed in certificates. And you cannot imagine what people do. They ask for new certificates. They want to change some wording. Some doctors do another vaccination, and they tell that this is for the rest of the life. There are 4 papers. There are 4 sheets of this document, and everything is written, even in Russian. So I strongly recommend that my colleagues read through this document. To crews, to ship owners, so that not to confuse our seafarers and avoid additional costs, because sometimes they have to fly to another city to be vaccinated, which is irrelevant. Our next speaker
is a person who probably knows a lot about the problems that our seafarers come across, especially in today's situation with coronavirus, when it's impossible to replace a person unrelated to coronavirus. It's Igor Kovalchuk, the vice chairman of Russian Trade Union of Seafarers, and he's going to be covering the topic of the crucial issues of medical support for seafarers. You get the floor, Igor. Please go ahead. Good afternoon, Ilona. Even though the name of Ilona stands under your face, I recognize you, Ilona, and I'm joyful that many colleagues are able to see me right now. Unfortunately, I couldn't take part offline. I wanted to be there with you in the audience, but I will try to share my screen now and work in this online mode. Can you hear me well? Yes, we can hear and see it well. So the question that I'm going to cover is, on one hand, is straightforward and simple. On the other hand, it's a complicated issue. In July 2013, a convention on maritime labor entered into force. I was in the audience when this convention was ratified. It was a voting that took part. So in 2006 it was ratified, and we were hoping that the Russian Federation will be implementing the requirements of this convention in a good speed. This Maritime Labor Convention presupposes certain requirements for different maritime aspects, including medical. The Russian Federation enforced the compliance with this convention, stipulating by regulation versus different ministries. So the Ministry of Health received the regulations 1.2, 4.1, and 4.3. which are the points of the conventions that have to be enforced by the Ministry of Health. So it should have entered in force in 2013, but unfortunately, it's been only after 4 years when the first list of diseases was the only legal act that was adopted in Russia to comply with the requirements of Maritime Labor Convention. Nevertheless, even this document is controversial. It gave a lot of room for discussion and the rest of the aspects that the convention stipulates was also discussed. The Ministry of Transport has a special committee, interdepartmental committee, that is responsible for the compliance with the convention. This committee includes different departments and ministries, including the Ministry of Health of the Russian Federation. These questions, controversial issues, were also reviewed during different meetings, such as the Committee of the Labor and Health Regulations. In the Russian Parliament, there was a special meeting dedicated to the medical care for the crews of ships in the Russian Federation. But nevertheless, this list is the only document that was adopted. Due to this fact, there are three issues: determining the order of medical survey or medical examination for seafarers and requirements for medical certificates of their health condition. Also, a list of medical organizations needs to be prepared, organization and doctors to authorize medical examinations for the seafarers. And the third point of interest is the need to determine a composition or what is contained in the ship's first aid kit or medical chest. About the present state of the medical checkups, I need to say that the Ministry of Health tried to tackle this issue several times, and some regulatory acts were created, but in the last version of this regulatory act, there was even no indication of any international requirements, even though we know that the Maritime Labor Convention should be mentioned and the STCW Convention, the International Convention on Standards of Trade and Certification. It is not there. They should be there, it's not there. And the Ministry of Health of Russia finally has developed the project of the law that takes into account the international regulations. This draft of a law at this point has went through the committee's review from the Water Transport Ministry. And the Ministry of Health, according to the latest data, are ready to present it in its in the way it is right now, so that the trade unions of seafarers and ship owners could assess it and evaluate this document. However, even though the list does include the color visions and indications and examinations, the latest requirement that was ratified it says that the medical examination should be in compliance with the international recommendations published by the International Lighting Commission, CIE. There is a standard that obliges it, or a similar standard. At this point, the methodology is not identified in this document. We hope that it is identified and included in this document, because at this point the color vision tests are being carried out, we can say informally, since there is no single document and single recommendation. Different medical commissions use different requirements. So we receive complaints from the seafarers. There should be different requirements to different crew members. The requirements should be different, for example, for person who stand outside and watch the outside sea, and to the persons who are sit inside, for example, of the control room, and they have to have a good color coordination of different lamps and indicators, and organizations or doctors who have a right to do medical checkups, medical examinations for the seafarers. This list needs to be also identified. Just until recently, the situation with the Ministry of Health was as follows. Any organization that has a license for medical services can provide medical checkups. However, it's quite obvious that the specialists who work for the medical examination of the seafarers need to have special knowledge about the peculiarities of work, about the specifics of maritime medicine, what are the typical diseases that seafarers suffer from. So it's obvious that this doctor or this organization has to be specifically trained. Oftentimes we see that incompetent specialists work on the medical examinations. We get complaints from the ship owners that the quality of the medical checkups is something that leaves much to be desired, and the quality needs to be higher. This being said, we hope that the work of forming a list of medical organizations and doctors who have a right to perform medical checkups will be somehow clarified and determined. Also, we do have different interaction with the organizations that provide the medical services to the seafarers, and we keep contact. We keep a close contact with centers of, we call FMBA, and the centers that do know the specifics of the maritime medicines. So we hope that they might be one of the operators for the medical examinations. Also, a form of special medical checkup needs to be both in Russian and in English. So the template should be created both for two languages, and as the latest info is that they heard us and it will be in both the languages. Another important aspect is first aid kit or first aid medical chest. The presence of strong painkillers in the first ship aid kit should be also linked to the training of seafarers. The system that is present now unfortunately does not allow to have strong painkillers on board, and this leads to many controversial situations. When a Russian ship comes to a Russian port, they have to have, or they cannot have strong painkillers, but when they come to a foreign port in a different country, they have to have strong painkillers. So you see that's a quite controversial situation, and that's something that a ship owner has also to take care of, to buy it, even if they to buy the strong painkillers when they are not being used even. It is also included in the Convention on the Drug the transportation of narcotic drugs is not considered to be a transit internationally if it's a part of a first aid kit. So some strong painkillers that are aboard are not considered to be luggage or import. They are considered to be a part of a special medical kit. So it's quite obvious that we have to work through the questions that I've just mentioned on the legal level. Moreover, the MLC contains also a requirement to have someone aboard who is able to provide medical health care, including also intravenous injections. So there has to be a person who is trained to do such procedures, to perform such procedures, and also the regulations should allow have strong painkillers, and these two factors need to be linked together so that we do have the one requirement for both, and it will facilitate the transportation in between foreign and Russian ports. Despite it's been over 8 years after MLC entered into force, the implementation of its medical requirements, it's still being hampered. That's the evergreen board that got stuck in the Suez Canal. So thank you for your attention. The seafarers are waiting. Thank you so much, Mr. Kovalchuk. I think that each statement that was shared by Mr. Kovalchuk could have been also discussed not only for one day, maybe for several days, but we don't want to get stuck as the evergreen in the Suez Canal. No questions from the audience.
We have a question from Thailand. In Thailand, they have a program that is developed by marine authorities together with the Ministry of Health, and they are based on international standards, IMO. This is a basic course, first aid course, which is 15 hours. The next one is 30 hours. And then for officers, it is a 100-hour course for first aid treatment, including in some emergency situations. Thank you very much. Our next speaker is Yuri Grabsky from the Federal Medical Biological Department of Russia, candidate of medical sciences, Deputy Business Development Director, Federal State Unitary Enterprise Scientific Research Institute of Industrial and Marine Medicine. The report is called Medical Supports Development for Ships Navigation on Northeast Passage. Dear Yuri, you have the floor. Hello, dear colleagues. I'm glad to see you, my colleagues and myself that are present here together with me. This year is the third time we see each other, which is very nice because the problems we are raising during our meetings are very relevant, and without close collaboration, it is impossible to solve them, to address them. That is why my today's report will be devoted to that detailed in his report all the complex support of all these documents medicine. Besides, it is planned to create these centers of health safety of seafarers at medical organizations within the federal state unitary enterprise which I belong to. There are some grounds for this, and we have begun work on this matter already. We have the necessary experience, but this will require some time. There is also a need to create a national research and practical center of maritime medicine in Russia that would unite and coordinate scientific research and their implementation in practice. And there is a need to create a federal research and educational center of Arctic medicine. We met with my colleagues several times at different conferences. There are some achievements already done in this area. My colleagues from Moscow and St. Petersburg are putting a lot of efforts to put those ideas into practice. What has been done so far, this year in particular? We can say that this is a serious breakthrough. Although the major stages will be implemented in the future, however, I see that we are moving in the right direction. We will soon publish the second edition of the concept of the development of maritime medical care. The first edition was prepared last year. It was reviewed, and this year we will have a second edition. The guidelines for cooperation in terms of medical care in the Arctic zone, first edition. There will be the second edition of the reference book on on ship and submarine medicine. In the second edition, there will be terms and definitions so that all the stakeholders and people involved into this sphere of activity talk the same language, speak the same language. The problem committee number 3 is created that will deal with actual problems of ship and submarine medicine, medical and biological medical assistance. We expect that the orders to create this committee will be published soon. Then we will develop the working plan of this committee. And our colleagues that are engaged into this problem for quite a long time have an opportunity to address the required issues. And there is a draft order of the Ministry of Health of the Russian Federation on the order of the medical inspection or examination, and the draft order on the requirements for the medical kit. All those documents are not approved. This takes time. This is not that easy. There are different opinions, particularly regarding the introduction of some changes into the legislative base. But we're quite optimistic and hope the future will be favorable. Yesterday and today at our conference, I heard a lot of interesting reports devoted to modern technologies and how they will be implemented. But you know, sometimes we need to go back to the past. This time, we're celebrating 85th anniversary of a very important event that happened in 1936. This is the transition of 2 military ships along from Kaliningrad to Vladivostok. A person who was responsible for the medical supervision, Vasily Shestov, is an outstanding military doctor, a legend of military medicine. He published very interesting, serious, and detailed reports regarding the navigation, and he personally participated in passing through that route in quite adverse weather conditions and tried to save health and life of seafarers. These are the large ships, Stalin and Voykov, that were passing through this route. This was a relatively not a very large ship, but still quite impressive for that period of time. And after that, Vasily was awarded an Order of the Red Banner of Labor. This is the composition of the emergency kit. You see not too many items, but that was sufficient enough for the expedition to be successful. This is another interesting example, a list of emergency food for 14 people for 15 months. This is a legendary trip. Georgy Sidov in the Arctic zone. This is the emergency food kit. People spent 5 months in icy conditions, fully autonomous. We know that the technologies are advancing, the medical drugs are different, the emergency toolkits are quite different. And we cannot predict 100% that the equipment will work well. Even the spacemen say that quite often things go unexpectedly. If equipment is functioning properly, the weather may disrupt the overall operation. But if the equipment and weather are good, then there is a human factor that is quite difficult to predict. That is why any serious tasks to solve such issues also requires a plan B, even for the medical stuff, in case something goes wrong, and all our regulations and plans and collaboration schemes will be irrelevant. So let's go to plan A. You have 3 more minutes left. We consider there are some requirements to change the legislative base of the Russian Federation regarding the maritime medicine. Talking about the administration of drugs according to health conditions, then there is a need to make some changes to the federal law, because this law doesn't create a regulatory base for those tasks. There is also a need to prepare some documents setting the requirements to the presence of medical rooms on board a ship, to the presence of drugs, including narcotic drugs, to the requirements to the presence of medical people. There is a need to develop a procedure for medical consultations on ship using telemedical equipment or telemetry. All this combined will allow to reach a new level of maritime medicine to solve complex issues of this sphere in the Russian Federation. Dear colleagues, thank you for your attention. If you have any questions, I'll be glad to answer them. Once again, I'm very glad to see all the participants of this conference. Thank you. Thanks for the organizing committee for inviting me to participate in this conference. We are ready. We are always ready to see you, either online or offline, and ready to move forward for the benefit of our common duty. Yuri, thank you very much. Thank you for your interesting report, for the work you are doing in this direction. Do we have any questions? There are no questions. Thank you very much. I hope to see you in the Arctic Forum in St. Petersburg in a few days.
Our last but not least reporter is from Aberdeen, Scotland. It's Graham Furness. Is the medical advisor for the OG UK, and his report is revision of the OG UK medical. Can you hear us?
I'll start sharing my screen and carry on with my presentation.
Yes, please.
So here we are. Okay. I can't see anybody. Can someone tell me, can you see the slides?
Not yet.
Can you see them now? I am sharing the screen.
Yes, now. It's okay.
Very good. Okay. So I know that this is the last presentation of the day and the last presentation of the conference. I know that you've already heard about pre-deployment screening earlier on in the conference. I know that you've heard about coronavirus on offshore installations and ships. I will talk a little bit about both of these things and tell you about revision of the oil and gas guidelines. So the UK itself is an oil-producing country, has been since 1964, so that's almost 60 years now. It is still a good place to do business because of its relatively stable fiscal financial climate, so that's a good thing. But the UK is not the biggest oil and gas producer in the world. It's about the 19th biggest oil producer. And the UK is not the biggest country in the world either. It's actually quite a small country, but we have oil and gas workers living all over the UK, and they travel up to Aberdeen, and then they go offshore to work. Now, because they're living all over the UK, what we have is we have a system of medical examination before they go offshore, and an offshore worker can get his oil and gas medical done by a doctor almost anywhere in the UK, because we have quite a large number of examining doctors. And I'll show you just some facts and figures. There you are. We have about 350 examining doctors in the UK, but actually we have a lot more examining doctors all around the world. In total, we have about 1,000 doctors now in 74 countries all around the world. And actually we do have examining doctors in Russia. We have 4 doctors in Russia. 3 of them are in Moscow and 1 of them is in Sakhalin. And you can see that actually overall now, most of the examining doctors for Oil and Gas UK are actually not in the UK, which is interesting. And if we look at the number of medicals that are done, you can see that that has increased greatly since 2008, which is when the current edition of the Oil and Gas Guidelines date from. The current edition of the Oil and Gas Guidelines, the medical guidelines, were written in 2008. And at that time, we were doing about 40,000 medicals a year. You can see that that increased to almost 150,000 medicals in 2019. It reduced a little bit because of COVID, but we're still doing a lot of oil and gas medicals. You can see that the failure rate has been remarkably constant over time, which is a good thing. It means that doctors are consistently interpreting the guidance, but we do need to revise the guidance because medical practice has changed over the past decade or more. And in 2019, we began a consultation exercise on revising the oil and gas guidelines. And I'll tell you something about some of the answers we got to that. But then, of course, what happened was that COVID started in 2020, and that did interfere with the revision process of the guidelines. It forced us to make some changes really quite quickly because of COVID. And the changes that we made are the ones that I've highlighted here. In a conventional oil and gas medical, everything is done in person. The examinee attends the examining doctor. There are tests that are done. There's a physical examination. And because of restrictions to medical activity due to COVID in the UK, we were encouraged not to see patients unless we absolutely had to. So we introduced an amended oil and gas medical, which was able to be done by video conference, just like we are doing now. And what it did was it tried to reduce the number of tests that were required. It reduced the amount of physical examination, didn't eliminate it altogether. And what it did was it tried to improve on the available medical history by making sure that examining doctors were provided with the previous oil and gas medical notes, provided with some information from employers, and perhaps some confirmation of medical history from the examinee's GP. So we introduced that really quite quickly under some pressure, but I think that in some respects there are some lessons to be learned from the introduction of this. And perhaps the first one to look at is the question of the questionnaire, the information that the examinee provides at the medical. And one of the questions we asked as part of the consultation was, do you always get an accurate medical history? And over half of responses to our consultation had a problem or had an instance where an inaccurate medical history was provided. And this is an example. This is an email that I received from an examining doctor. They had done an oil and gas medical on a 45-year-old man. That person said on his questionnaire, and when questioned directly, that examinee said that he had no significant medical history, and he said he was not taking any regular medications. He was normal on examination, So the examining doctor gave him a 2-year normal oil and gas certificate. A few weeks later, the examinee got back in contact with the examining doctor and said, I wasn't truthful. I'm actually taking bisoprolol and rivaroxaban, an anticoagulant, for atrial flutter. And quite correctly, the examining doctor was concerned about that for someone going offshore and asked me what to do about it. So I dealt with the inquiry, but there's an example of inaccurate medical history. So what should we do about that? Should we confirm the examinee's medical history in general? Well, this is a slightly deceptive slide because it begins at 46% there, but the answers that we got were somewhat split. It's almost half and half of people felt that maybe we should improve on the medical history. So a little bit controversial, but with the amended oil and gas medical for coronavirus, we have introduced a stronger medical history. And actually, I think it has worked very well. I think the option of getting, or the requirement to get some questions from the employer answered, those are questions such as, does the employer know if the person has been off sick? Does the employer know if the person has been medevaced? Does the employer know or have any concerns medically about the employee? These are quite useful questions to get answers to. Having the previous oil and gas medical notes is also very useful because often things are documented there that the examinee may not tell you about this time. So this in practice has proven to be a very good and useful thing, and I certainly think it should stay. The topics that people were particularly interested in seeing revision to in the guidance were cardiovascular problems, obesity, medications, diabetes, and psychiatric problems. And we'll just look at a couple of those just quickly. The oil and gas medical doesn't actually require measurement of blood pressure. That's an interesting thing, is that the normal oil and gas medical doesn't actually require measurement of blood pressure, but everybody does it anyway. And we asked the question in the consultation, this is a clinical question, how often should an apparently well adult have their blood pressure measured? And these are the responses that we got from doctors in the UK. And it ranged from, some doctors thought it should be every 6 months, some doctors thought it should be age dependent or maybe every 5 and 6 years. There is actually an answer to this question because in the UK we have a set of medical guidelines, the NICE guidelines, which tell us to measure blood pressure every 5 years in apparently well adults. So 5 years is the correct answer, if we want to call it that. But you can see the variation there. Just for interest, here are the answers from the doctors outside the UK. I don't expect those doctors to know what the NICE guidelines say, but you can see that there was an interesting range of answers going from once a month up to rarely, which is interesting in itself. But here's an audit that I did of 56 medicals, oil and gas medicals done over a period of time. And what I found was that just under half of those medicals had a blood pressure above what the NICE guidelines recommend for further investigation. And the interesting thing is that virtually none of these, I think 1 or 2 of these, had actually had some follow-up of those blood pressure readings, but most of them had not. And I do ask myself the question, what is the point in measuring something at a medical if you're not going to do anything about it? And therefore, I think that we need to be more prescriptive in the oil and gas guidelines in the future. We did ask that question, should the guidelines provide greater prescription about what is required? And most people said, yes, please, more prescription rather than less. And I do think that that is going to be a feature of the future oil and gas guidelines. I have already started revising the blood pressure section to be more detailed and prescriptive about that. There is one other aspect of tests that we can look at, which is a little bit more controversial. There you are. You can see that the normal oil and gas medical says that we should do urinalysis on all examinees. We changed that in the remote medical, the video medical for COVID, and we said, don't do a urinalysis. Now that, in the consultation exercise that we did, was much more controversial. We asked the question, should urinalysis be omitted from the medical? And most respondents said, no, it should be retained. But what is interesting about that is that there is no medical organisation in the UK which recommends routine urinalysis on every single person that we see at a medical. And the question there is, what are we testing for? And is actually urinalysis the best way to test for it? Because perhaps something else might be different. So this is more controversial. We shall see what happens with that one in future. Thinking about weight for a moment or two, here is another audit that I did of oil and gas medicals. And it's a small number of cases, but you can see that most people, where we have a record of 2 measurements of their weight, 77% of people put on weight in between their oil and gas medicals. So this is a continuing problem. And we asked the question in the consultation exercise, can we set a cutoff, a pass-fail cutoff for the question of obesity of people going offshore? And most people thought that we could do, although actually people representing contractors offshore, the vendor population, were less keen on that. But most people thought we could set a cutoff. But when you look at the detail of the answers, the people who thought the cutoff could be body mass index, it ranged from a cutoff of a body mass index of 33 to a body mass index of 50, which is obviously quite a wide range. There were 1 or 2 people actually who mentioned a functional test or a physical capability assessment, and we'll bear that in mind in a second. There were some people who mentioned weight as a criteria, but again, it ranged from 120 kilos up to 150 kilos, which again is quite a range and not a consensus. And then there were various other suggestions for fitting through helicopter windows, and some people who mentioned a fitness test. It might be better dealt with by a fitness test. And one of the interesting things about the revised oil and gas medical is we did introduce a functional test, a practical functional test. We did it for respiratory disease because the normal oil and gas guidelines for chronic obstructive respiratory disease mention spirometry values, and for COVID reasons, we're not doing spirometry. So the normal guidance does mention a practical functional test where spirometry isn't meeting the standard, but it doesn't say what that test should be. So for the revised oil and gas guideline, we actually said what the practical functional test should be. And it's very simple. It's just a timed, self-paced, continuous brisk walk of 1 mile or 1.61 kilometers distance. And it says the time that they should be able to do that in, which is they should be able to do it in less than 19 minutes. That's actually very generous. Try it for yourself. Go for a brisk walk and see how long it takes you to cover 1.61 kilometers and see if you can do it in less than 19 minutes. I hope you all can. So we have introduced a practical functional test, and I do think that that simple practical functional test will go into the revised guidelines, not just for respiratory problems, but for obesity as well. And then the final comment I'm going to make is just one other big lesson from COVID is that it has surprised me just how readily and how easily the industry has adopted the idea of a pre-mobilization check. Up until 2020, the only thing you needed to go offshore was your oil and gas medical certificate. From 2020 up until now, because of COVID, you cannot go offshore unless you have a check, a COVID test, and perhaps a temperature test before you actually go offshore. And I did suggest, Oil and Gas UK had a health and safety conference earlier on this year, and I did suggest at that we might do something more. We might keep a pre-mobilization check and do something more with it. You know, maybe we might check blood pressure before a person went offshore. Maybe we might check weight before a person went offshore. maybe we might check what medications a person was taking before they went offshore, rather than have them come back from offshore when we find out what they're taking offshore. And then the question of mental health has been one of great interest. And I did suggest that maybe we might just check, are people feeling well enough mentally to go offshore? But it was interesting that the response I got to that suggestion was not enthusiastic. So I don't know if I should have been surprised at that or not, but there wasn't enthusiasm for that pre-mobilization check. So really, in brief summary then, my conclusions from my experience of the revisions that we've made with the oil and gas guideline for COVID and the consultation exercise is that I think that one of the most important things we need to do is to think about how we can improve on the accuracy of the medical history. I think that a big lesson about tests is that if we're going to do a test, we should really do it properly and act properly on the results. And I think that for some things, we can actually introduce a nice, simple, pragmatic, functional test without too much complication. I think that's the best sort of test to introduce. And I do think that the industry appetite for a non-COVID last-minute check is doubtful. So I think that it will still be the oil and gas medical that will be the way that we will do things in future. So that's really just a brief summary of my experience over the past year and a half or so. So I'm happy to take questions from anybody, if there are any.
Если у нас вопросы из зала. There is no questions. Thank you for the brilliant presentation.
You're welcome.
Thank you.
You're welcome.
Я должна сказать, что Грэхэм, как атлант, он на своих плечах держит.
Graham is like the Atlantis. He, on his shoulders, is pulling the whole horse for the training of the OGUK. I was one of the persons who was certified at the OGUK trainer, and I had a pleasure of meeting him. So he was training us for the whole day without any pauses and breaks in one building.
Just a moment.
Я правильно понимаю, вы одна из 4 врачей из...
Ilona, are you the one of the 4 people in Russia who has the certification? Yes, I'm one of the 3 in Moscow.
And have you been doing remote medicals?
Yes, I do. From the beginning, it was really strange for the patients, but it's quite okay. It's quite okay because, you know, if the person has to travel from Murmansk to Moscow as a clinical, you know, physician, I personally prefer to do it online and not to put him in danger, you know, to the exposure of virus.
Yeah, no, very good. So you've been able to make it work and it's worked well for you. So that's a good thing.
Yeah. Thank you. Я одна из
welcome.
тех, которая еще делала вот на расстоянии эти сертификаты АГУК в начале.
All right, so she's also explaining it again in Russian. So I was one of the first person who did the OGUK remote tests, but it was weird initially. But as a clinicist, I would say that it's easier not to travel from Murmansk to Moscow than to put a person in danger of contracting a virus on their way. We had different other efforts enable maybe to extend the OGUK certificates maybe more than 2 years for us not to do additional tests, but hopefully very soon we are about to see the end of the pandemic time. Thank you so much, Graham. Our conference is now about to end. We will have now 15-minute break for the technicians to change the configuration in the hall. But please, audience offline, be back.
Dear colleagues, it's time to close our conference. It's a little bit sad because during these 2 days we had a very fruitful and efficient discussions. And in general, the agenda was fulfilled. I would like, taking into account that I was given an opportunity to moderate this closing session, to sum up the results of our conference. To sum up the results of this important event that we were part of. First of all, I would like to say that this conference was very specific. It was different from the 2 previous conferences that were held in Tomsk. But to my opinion, now we have a clear a multidisciplinary approach which fits well within the topic of the conference. It was clearly obvious even at the plenary session and during the discussions within the sessions. What do I mean by this? It is clear that the conference is about medicine, but besides medical issues, we managed to cover the issues related to legislation, business processes, environment, the issues of medicine in general and medicine in remote sites in particular. Such an approach makes it possible to develop the platform for discussion that will help us in the future to arrange work in remote sites more efficiently. I will always repeat that the work that we are doing is very important. And first of all, this is relevant for people, for Russia, for our country, because this solves partially the demographic problem. We have already mentioned this time ago. We have talked about the influence on the working population. This is the format that allows us solving a variety of issues related to the demography, which is quite acute for Russia these days. However, this problem is the most urgent problem, but working in remote sites is our daily routine, is a very hard work, and we all understand how the importance of this work to be clear, to be understandable for customers, for medical support staff. That is why I'm very glad that we had this type of discussion, and I'm sure that it will bring successful results. The second aspect I would like to highlight is that this conference was arranged in a hybrid format. Right now, this is a fashionable word, but it was held both online and offline. It turned out to be that due to some circumstances, we were forced to apply these and combine these 2 modes of work. But to my mind, everything went well. Due to this hybrid format, we were able to engage 500 people to our discussions. At the last conference, there were 150 people present. But due to this opportunities that the modern time is offering to us, we are able to attract more participants. But as the organizers tell me, 500 people were participating in the conference. This is a great number. This includes both online and offline participants. Me, as one of the organizers, can confirm that this is cost efficient because the offline costs are quite large, but I think the effect it will be even more efficient from such a hybrid format. That is why I suggest we use this tool in the future, and I would like to thank our technical support staff, the Profix company. Guys, you did a great job. Are you still alive? I would like to say that you did a really good job and without any interruptions. That is why we are quite thankful to you. You have been supporting us in many events. Then I would like to say that the peculiar feature of this conference is that we managed to bring a new vision. This is not our vision, but this is a commonly accepted vision that came from the UN. I mean, sustainable business development, the global treaty. We had an executive director of this global treaty present at our conference. This is a new vision that is focused on the quality, on person and then money. I think this is important to change our mindset, to change our vision in this specific area and focus more on quality. I'm very glad that we are introducing this system in Tomsk, and we are about to sign the corresponding agreement on corporate volunteering. And the CCM is becoming will be the representative of this branch in Tomsk. There was a roundtable discussion in the trade union. In the administration of Tomsk region. This is a new technology for us. This is something new for us that makes us different from others. Besides, we managed to expand the scope of our discussions. We were talking today a lot about marine medicine. There were 2 roundtables in St. Petersburg and Moscow. And within the framework of this conference, there was a separate session devoted to those issues. That is why I believe that the conference was successful. And I would like, by summing up, I would like, and another point I forgot to mention, the specific feature of this conference is the outstanding members of this conference. I'm grateful to the speakers that came to participate offline. I'm thankful to those that were in the online mode. I'm amazed by the geography of our participants. We listened to reports of experts from Latin America, from North America, many reports from the United States of America and Canada. Europe was also present, Asia, Russian Federation as well. Was also giving their expert view, presented new case studies, new vision. Africa was also giving some presentations, the Central Asia. The pool of new knowledge, expert knowledge, that was shared today within this conference is quite impressive. And the level of reports, the level of organization of this conference allows confirming that in general we were able to fulfill the task set by us at the beginning. Right now I would like to give the floor to the moderators that are offline to sum up the results of their work, and they will tell in brief about the distinctive features of their sessions. What was new, interesting, surprising, and so on. Maxim Kurbanov was moderating the session on innovations. This was a very interesting session and discussion. Thank you, Sergey, for giving me the floor. I think the conference was amazing. It is the first time I'm here. I was reading a lot of feedback about the previous two conferences, but the platform is unique and the speakers are experts of the highest level from different parts of the world who presented very interesting reports. And we got an opportunity to listen to the reports and cover a variety of topics. And besides, we had an opportunity to ask questions and receive the corresponding answers. Sometimes the discussions were going beyond the format. They were too active sometimes, but which is also good to my opinion, because people share their knowledge, share their experience. Within my sessions, there were many ideas, interesting ideas. Our colleague from Vietnam made a brilliant presentation on telemedicine. Our colleague from Norway also made an interesting report on a training course that can be used in remote locations. This wide experience by our company and our respected colleagues will be improved in the future, will be expanded so that we continue our work successfully, improve our systems that are being integrated, and the new technologies and modern technologies that we are using in remote healthcare. This is done in order to create more efficient models for medical healthcare in remote sites. Once again, I would like to thank all the speakers and participants for their active position, contribution, and interest. And I think you will all agree with me that we will be happy to see you once again at our next conferences. Thank you very much. Thank you, Maxim. I would like to commend the session on industrial hygiene, because Andrei Karchevsky was the moderator of that session from the USA. I think right now it is night there, and he cannot comment. This is the second time that we are discussing those issues, and I see how the discussion has improved. Andrei Karchevsky was very efficient as the moderator. He was able to invite the experts in the field of hygiene in remote sites. All the reports were from the United States, most of them. Unfortunately, Russia is lagging behind the experience of the United States. But I think this advanced experience should be shared, should be introduced and implemented in Russia in the future. I cannot but mention the brilliant report by Boris Revich, who is a legend in medical science, of the Russian science. He's part of the Nobel team. And for us, this is a great honor that he was able to participate in our conference. He is very popular in the scientific community, and he delivered 2 lectures in the medical university. And I'm very thankful to him for this, for his contribution and for giving us this opportunity to talk to him. This is great. Thank you very much, Boris. Right now, I would like to give the floor to Ilona Denisenko. I'm very glad that it's not the first time we're organizing such a conference together. She's an expert in maritime medicine. Ilona, can you comment a few words? You just arrived and came to the right to work, but everything was great as I see it. But can you say a few comments? I'm thankful, first of all, to the organizers. It's the first time I'm in Tomsk, and I hope I will come back here again. But I will repeat the hybrid and multidisciplinarity approach, because in maritime healthcare we need such multidisciplinary meetings and sessions in order to understand what is really needed, what do the seafarers really need, what the ship owners need. And you were able to do this to your best, because during conferences as such, we are only able to discuss the urgent topics. The hybrid approach, this is so great to be part of the offline part of the hybrid approach, to see your colleagues face to face and have an opportunity to talk in person. I think sometimes this hybrid approach is very useful, because sometimes it is very difficult to come to terms from another country, like from Thailand. But we should always think that many colleagues are willing to visit another country and visit Tomsk. Conference is not only participation, but this is traveling, this is visiting another culture, and we are people, we are humans, and we always like to do this. And I would like to say thanks to the technical team, because this is a great job done at the highest level. The agenda was quite interesting and well thought through, because you were able to build agenda so that it is convenient for all the people from all parts of the world, considering the time difference and so on. I also would like to say thanks to the translators. All my colleagues were amazed by the brilliant work of the translators. They say that the translation is ideal. Thank you very much. Thanks once again. I hope that this is not the first and the last time we are here in Tomsk, and I hope to see you very soon. Talking about your remark about the visit to Thailand, people are willing to go from Tomsk to Thailand. This is a different situation here, because it is cold here and people want to go to warm places. But I agree with your point of view that it is better to communicate in person. It is different emotions. Once I was participating in the conference and we had speakers from 16 countries, and one from seized countries and non-seized countries, like Kubat Rahim from Kazakhstan, Dr. Nahyan from the far abroad country, but I'm sure they are happy that they were able to make it here. I would like to give the floor to medical aviation session, Yuri Kardakov. Thank you, Sergey. First of all, I would like to thank the organizers of this wonderful event. Everything was organized at the highest level. I would like to thank our speakers, participants, and our colleagues and reliable partners who participated in the work of our conference. The session on medical aviation covered a variety of issues. There are so many of them that it is difficult to fit them within one session of the conference. But in brief, they can be characterized as follows: people, equipment, and the regulatory base. Use of equipment and personnel. I think this is applicable to all our events like aviation, maritime medicine, emergency aviation, helicopter, and aircraft aviation, and so on. So the problems are pretty much the same. Despite the fact that the medical aviation dates back many centuries ago, the opinions of scientists are different. Unfortunately, this experience was lost, and we have to accumulate this experience again. We were trying to search for some facts ourselves, but we fail sometimes. So we are writing the history from scratch, and we are the ones that have to find the answers to the urgent questions, to the topics that we are all interested in. Our colleague Anton Kosovets made a report and suggested the solution related to the licensing of aviation and equipment that is used there, and I think this will be implemented someday in our country. We saw how the evacuation of injured people is performed from the marine platforms. We saw nice examples of medical evacuations using aircrafts and different equipment. And my colleagues told me that we always need more equipment. No matter how much you take, there is not always enough. Our main goal is to make sure that the patient survives, not injured and not sick. So I would like to thank you once again for nice and fruitful work, and all the answers that we were able to get through the discussions will contribute to better work and will be useful for all of us in the future. But our big dream is to unite aviation, medicine, and customers as a single operator, and I think this will happen someday in the future. Thank you very much, dear colleagues. Yuri, thank you.
I'd like to speak more about the training remote. There he is. Let me introduce him to you if you don't know him. Daniil Starostin is a director of the ITLS course Russia, and I think that he will be cascading all the best practices here in Russian Federation. I hope you don't mind. I just really wanted to introduce you to everyone so that everyone knows what the ITLS leader look like. And ITLS is only in our chapter. So we are the only chapter who's providing ITLS training, where Daniil is the leader. About the section on the whole, I'll say that it was quite interesting. Quite interesting instances from European medical training, and interesting, great experience, amazing experience from Dmitry Suslov. Dmitry Suslov is from the Special Forces senior instructor from the Spetsnaz Russian University, and I'm happy to see them here at our conference. I'm happy to see them starting to talk, to interact with us. So this support from Army will only make the training for the civil medics better at the remote locations, and I'm glad to see so many best practices from all over the world being shared. Some of the practices you could say are somewhat competitive between each other, among them, and we can trace some continuity in terms of what the training should look like, who should be involved, and so on and so forth. I'd like to give the floor to one of the organizing committee's chair, to the Professor Karpov, Andrei Karpov. It's been the third conference organized by the Institute of the Remote Healthcare, and I am extremely glad to see this conference happening in Tomsk. So I really want it to happen in Tomsk and to keep happening in Tomsk, because even though it's kind of not the easiest location to get to, it is a conference of the remote location. Medicine, so remote medicine, like there was a joke about the airport being closed, so we are truly a remote location because of that this time. Thank you for the introduction. I would like to thank all of the participants, both offline and online, who was brave enough to travel at this time. And if we speak about the history of our conference, during the first conference, the scope of the topics that we discussed was far less, and we only thought about the aspects of organization of the remote location. And for us, it was a challenge. We thought it would be a challenge to find some topics for the next conferences. Nevertheless, right now we see that as our audience broadens, as our pool of experts broadens, we see also maritime medicine, and we heard Ilona, who is a captain of this section. She was leading it forward. So I think that we will be adding new participants and some new issues that will be interesting for everyone. And here I mean that there are two things that I would like to mention. First, the participation of the industrial companies. Even up to date, we are not able to get any speakers of the SHE or HSE from major businesses, and I know that they have enough problems in what relates to the personnel, to the employees. And here we want to underline that the main capital of the company is not the equipment, and it's not the raw material, but the main asset is people, is its employees. And the reputation can only be won by how the company treats its people, its personnel, and how it's taking care of the well-being and health of the people who work there. So in our conference, we're trying to demonstrate the value of new measures and new approaches that help to work with to improve the health of the employees. I had a friend who was telling me that you can't really avoid the problem. You have to go towards the problem. Only this can help you. And the second issue that I would like to note is because we can feel this hunger of the medical employees or medical labor. The amount of remote medical objects is only growing, and we need even more and more medics who are ready to provide effective medical care at the remote locations, which is why we will be more actively engaged in medical universities in order to and even though we know that the experienced personnel is hard to get for the remote locations, whereas the younger people think they tend to be romantic and romanticizing new experiences and new locations and ways for the for getting new experience. So we see a point for direction here, and we need to see better integration among the specialists, because very often we don't know what's going on in Tomsk Polytechnic, for example, University, Tomsk State University, what research do they have related to our sphere. Nevertheless, they might be also working for the benefit of all of us, and we shared the list of the competencies and skills that has to be obtained by certain knowledge, and we would like to see this integration in action. Like Sergei already said, it's always a little bit sad that something good is going to an end, but some bad things, like the pandemic, for example, also cease and come to an end, which is why hopefully we will see you again and see some new friends as well. And the organization committee is now drafting the memo, which will be presented to you in its final form. We just need to agree on this memorandum. If anyone has any suggestions or ideas that you would like to add, we just tried to sum it up. Memorandum of the Third International Conference, the Remote Healthcare, Sustainable Development. The Third International Conference Sustainable Development of the Remote Healthcare was held in Tomsk on the 9th and 10th of September 2021 by the Remote Healthcare Association with the help of the Tomsk Region Administration, Tomsk Siberian State Medical University, the Center of Corporate Medicine, and the International Institute of Remote Healthcare Association. Over 500 people took part in this conference from 17 countries, also representatives of the authorities, major businesses representatives, professional unions, representatives of the universities and the academics, experts in the occupational hygiene and healthcare. The work was aimed at attracting attention to the improvement in the remote healthcare, which is the basement, the foundation of achieving the best results and improvement of the healthcare in general. We tried to cover the topics of the remote healthcare on the remote objects using the new technologies. The participants consider the strategic goals to be of significant deterioration or significant drop of the morbidity and mortality via building the best efficient system of remote health care or the remote locations. To achieve this goal, we need to implement the following tasks. To work through the list of suggestions for norms and regulations that will be demonstrating how the remote medical care should be provided. Adapting the guidelines for the international use and future use of the universities and major businesses. Create a standard of the extended medical checkup that allows to find out threats, life-threatening conditions for the employees working at the remote locations. Build a technology of forming a single medical system for the diagnosis and monitoring of the healthcare risks, using the one single base or database for the healthcare risks. New activities and steps should be taken to find out the ways to mitigate the risks. Thank you. The memorandum will be available at the conference website. This is not the whole memorandum, but if you would like to see the whole thing, you can get acquainted with it on the website.
I would like to state that the Institute of Remote Healthcare, as a non-profit organization that governs different discussions and fosters expert opinions in the field of remote healthcare, and I would like to ask everyone present here, those who listen to us, to be active and collaborate with the Institute of Remote Healthcare to discuss the urgent issues. And though everything that was mentioned in the memorandum, we believe this will be included into the legislation, but we really want to create the market of remote healthcare services so that the customers understand what is happening, the providers understand it, so that this area of knowledge is efficient. That is why I'm very happy that we have this institute, and I'm calling upon to be active all the time. To continue our closing ceremony, have a very nice mission, despite the fact that we are all very busy people. Some of you came here and the others came on the eve of their birthday, and the Center for Corporate Medicine would like to congratulate those people who, that despite their holidays, despite the celebrations, came to participate with us. Ilona Denisenko had her birthday on the 7th of September. Our small gift to you. Thank you that you are working with us, that you are collaborating with us, and it's great that you managed to come to work at this conference. Wish you all the best, prosperity, health. You're a brilliant expert, a very beautiful woman, so wish you all the best. I also want to congratulate Kubat Rahimov. He had his birthday on the 8th of September. His trip to Tomsk was very difficult and tough, but I would like to say that CCM managed to find a good friend, first of all, in the person of Kurbat. Besides an expert in the field of politology and understanding the development of medicine in Central Asia, it's a great honor that you are part of our team. I'm glad that we invited you to participate at this conference, and the report you made was amazing and very important in terms of remote healthcare development. It is clear that the territory of the Central Asia for the Russian Federation was strategically important, has always been strategically important. You were able to disclose this issue and to reveal this to the wider public. Kurbat is an expert of the highest level. We want to congratulate you on your birthday. This is a small gift for you from Tom to have good memories about Tomsk. Wish you all the best, well-being, health, and success. Thank you. I would also like to say the words of gratitude to people that made this conference happen. There are only 4 people, you will not believe it. They were able to arrange this, just 4 of them. This is a miracle, and I am proud that I'm working with these people. I'm proud that these people work in CCM, and I would like to name them personally. Alyona Turlova, Alexander Kalatvinov, Nikolai Yuriev, and of course, Yelena Shostazub, director, the inspiration person, and the main organizer. Thank you guys for the work you did, for this fantastic experience that you gave to us. I know how worried you were and how difficult it was, but thank you once again. Dear colleagues, dear friends, I shall announce the 3rd International Conference closed. And I'm inviting you for the banquet.